that we are hosting in Pretoria at the Fire and Ice Hotel. And our hosts are the SMU University, and it's very exciting to see such great developments happening in South Africa. Well, as we are preparing for these oral presentations, hopefully Technical will be able to get them up very soon. I want to remind you that we'll have a couple of segments here. The first segment is going to have 4 presenters, and then from there onwards, we'll have an address from Professor Mujerere. After that, we'll have another 5 presenters. No, excuse me, it will be 4 as well, and then Professor Mujerere. After that, there will be 6 presenters, and Professor Situsa will give us an address, and then 3 more. Professor Situsa will give us an address after those presentations, and then there will be 1 that Professor Mupulai will be giving us an address to. Interact with us on our WhatsApp page or WhatsApp number, which is 064 656 0131.
Today, my name is Emma Musekene, and the topic of the study is needle stick and other sharp injuries, with focus on the occurrence and the risk factors. And this study was conducted among dental students who were attending within the university in South Africa. And this study was supervised by Dr. Mujaji, and it was funded by the Department of Public Health within that university. Background and literature review. And this presentation will give a definition of needle stick, which according to literature is defined as a skin wound caused by accidental needle prick. And then this can occur when performing certain procedures or during treatment of patients. It is also, according to literature, classified as an occupational health hazard, which affects most health workers, which in this case include dental students. Why are the dental students at risk of needle stick? According to literature, it's because the oral cavity that the dental students works on requires close proximity between the students and the patients. And also the procedures that the students are expected to perform also require a specific competency or a skill which student might not have. And then the use of sharp instruments more often when they perform those procedures. And then what are the causes of needle stick according to literature? It is mentioned to be inadequate knowledge and non-compliance regarding the prevention and management of needle stick injuries as one of the causes, and also lack of experience among students and the knowledge on how to handle those instruments when working with them also causes needle stick injuries according to literature. And the factors associated with needle stick injuries with literature shows that poor compliance of students in infection control measures also one of the factors associated with needle stick. And the other factor is that the study level of students, which in this case shows that most students who are at their final year are exposed to needle stick injuries than those who are at their first and second year level of study. And then again, the issue of inadequate knowledge on blood-borne diseases among dental students also it's one of the associated factors on needle stick injuries according to literature. And then what are the contributory factors in African countries? And then it is shown that, and then work experience, which is very low in health workers, and then also the issue of fatigue contribute to needle stick injuries, and then the issue of abnormal working hours among healthcare workers also contribute, and then the issue of improper use of PPEs, which is one of the contributory factors which cause needle stick injuries in African countries. The aim of the study is to assess the occurrence and the risk factors of needle stick and other sharp injuries, with the objectives to determine the prevalence of needle stick and also to determine such factors associated with the occurrence of needle stick. A cross-sectional study was conducted among the dental students who were registered for various professional categories, which includes dentists, dental therapists, and oral hygiene program. The students who were registered for 2nd to 5th year level of study form part of the data collection process. And the process excluded 1st year students as they don't perform clinical training. Data was collected using a self-administered questionnaire where 248 dental students participated on data collection process. The results shows 41% of prevalence of needle stick and other sharp injuries, with all levels of study affected, although most affected level were the 4th year with 57% and the 5th year with 56% of injuries. Among 41% of the students who experienced needle stick injuries, there were various causes of needle stick injuries recorded. And then the lack of concentration was one of the highest common cause of injury, which was recorded at 36%, followed by anxiety, which was recorded at 19%. And there were other causes like lack of experience, fatigue, and lack of training as recorded in the results. And then reasons for not reporting, students indicate fear of consequences as one of the common reasons for not reporting, and then followed by long procedures which student has to follow when reporting needle stick injuries at 26%. And then another cause for concern was lack of knowledge, which was similar to the student who never reported the injury, as there is lack of knowledge among those students. And then it is a cause for concern in this study. The study also assessed the procedures which dental students were performing when they got injured. Among the procedures were injecting a patient, which was one of the highest procedures at 34%, followed by scale and polishing at 26%. However, there were procedures like tooth extraction, root canal treatment, root planing, which were also recorded. And then the study also indicate instruments which were used during injuries as needle syringe, reported to be at 52%, and scalers, which were at 31%. And the most common departments where the injuries occur were reported to be periodontology department at 39%, followed by maxillofacial and oral surgery department, which recorded 25% injuries. With various analyses conducted in the study, multiple regression analysis shows significant association of sharp injuries and academic year of study. The results also shows that being in the 3rd or 4th or 5th year of study, it's significantly associated with the likelihood of needle stick and sharp injuries. This is reflected by the p-value, which is less than 0.005 as recorded in all the academic years. This study also assessed the precaution and preventative measures which the student perform after injury, with about 23% reported they have done nothing, which is a cause for concern. However, 43% of the students indicated they just wash under tap water, with 8% who received prophylaxis and about 5% received medical advice and blood tests. With regards to universal precaution, about 11% of students never use universal precaution when got injured. And then vaccinated of hepatitis B, also 1% of students were not vaccinated during the study. And then about the training, and the study indicates 24% of students were not trained on instrument handling and also on blood-borne diseases, which is also expose students to needle stick injury. Conclusion to this presentation: needle stick injuries is identified as a common challenge among dental students, more especially at their final year of studying. And however, there are various instruments and procedures which students are expected to perform which also predispose them to needle stick injuries. And there are other factors which influence needle stick injuries, which include lack of concentration and fatigue. And those factors can also be reduced if enough time is allocated for students during their clinical trainings. And also, the burden of needle stick injuries can also be reduced among dental professions if they adhere to universal precaution measures which are meant to reduce needle stick injuries. Following were the reference used during presentation. Thank you.
Good day to one and all. I'm Dr. Veli, and today I will be presenting the research topic, a 5-year review of the scope of pediatric maxillofacial and oral surgery at the Wits Oral Health Center. Pediatric maxillofacial and oral surgery is an ever-increasing field regarding the management and the surgical focus of patients. The field is overlapped by various specialties including maxillofacial and oral surgery, plastic and reconstructive surgery, otorhinolaryngology, and pediatric surgery. Pediatric patients pose a unique challenge to clinicians with regards to the anatomy of patients, physiology, behavioral management, and compliance. The most important consideration when dealing with pediatric patients is growth. There exists sufficient research from the various subdisciplines of pediatric maxillofacial surgery. However, there's no synthesis on the data to be able to assess the entire scope of pediatric maxillofacial surgery. In 2008, the World Health Organization identified that childhood trauma would most likely be the #1 disease globally by the year 2020. Jones and Franklin in 2005 identified that tooth-related pathology was the most common pediatric pathology in the maxillofacial region. Nayak in 2011 noted that although squamous cell carcinoma was the most common cancer of the maxillofacial region, it is extremely rare in the pediatric population. And in 2017, Ruiz identified that recent evidences suggest that patients present with temporomandibular joint disorders early in life. Study design and population. This is a retrospective record review study done at the Wits Oral Health Center, which includes Chris Hani Baragwanath and Charlotte Maxeke Academic Hospitals. All pediatric patients who presented to the maxillofacial and oral surgery department at the Wits Oral Health Center were included in the study. The study period was from January 2013 to December 2017. Ethical considerations. Ethical clearance was obtained from the Human Research and Ethics Committee. Permission was obtained from the CEOs of Chris Hani Baragwanath and Charlotte Maxeke Academic Hospitals for the use of patient records. All patient details and records of these patients were kept confidential. Data collection. All data was obtained from the outpatient department and the theater surgical logbooks. The demographic data compiled included age of the patient, gender, and indication for treatment and procedure undertaken. Data was sorted into years and then further assessed with regard to the 5-year period. The results. Over the 5-year period, there were 694 patients who had presented to the maxillofacial and oral surgery department. The majority of patients were males, making up 54.18%. This was 376 patients, whilst female patients accounted for 45.82%, which was 318 patients of the total number. The age group distribution. The mean age value was 12,53. The median age value was 7 with a modal age value of 17. The standard deviation of the data set was 4,362 with a variance of 19,028. Patients aged between 11 and 17 were seen the most in the department. They accounted for 70,03% of patients, while patients aged between 0 and 5 only accounted for 9,08% of patients. The number of patients seen in each discipline per year. Oral surgery was the most common surgical procedure, contributing 234 patients over the 5-year period. That amounted to 33.72% of cases. The most common oral surgical procedure performed was the removal of impacted teeth, amounting to 151 patients. Maxillofacial and oral pathology was the second most common presentation to the department, with 199 cases. 27 different types of pathological conditions were identified. The most common pathology was an ameloblastoma, which occurred in 15.7% of biopsies. The most commonly diagnosed classes of pathology were odontogenic cysts, contributing 23.15%, benign odontogenic tumors at 22.31%, and fibro-osseous lesions at 19.02%. Trauma was the third most frequent discipline of pediatric maxillofacial surgery, comprising of 142 cases over the 5-year period. The most common type of trauma was mandibular fractures, and males between the ages of 11 and 17 were most commonly affected. The fourth most common presentation to the department was infection and sepsis. Over the 5-year period, there was a total of 57 cases. Craniofacial surgery, consisting of cleft lift and palate repair, and facial reconstruction post-tumor ablative surgery, came in fifth, contributing 35 cases over the 5-year period. Orthodontic surgery was only performed in 13 cases over the 5-year period. 8 pediatric patients presented with temporomandibular joint disorders, the most common being TMJ ankylosis in 6 of these patients. Oncology and implantology were the least commonly performed procedures. Oncology only saw 4 patients over the 5-year period, and implantology 2 pediatric patients over the 5-year period. The findings of the study indicated that there is a high incidence of pediatric trauma in males between the ages of 11 and 17. These patients accounted for 53.52% of all trauma cases. Mandibular fractures were the most common presentation of maxillofacial trauma. With regard to pathology, odontogenic cysts counted for 23.15% of cases, odontogenic tumors 23.15%, and fibro-osseous lesions. These were the most common classes of pathology that patients presented with. Salivary gland pathology was extremely rare in the pediatric population. However, mucus extravasation cysts were the most common form of salivary gland pathologies. In conclusion, a large variance exists in the scope of pediatric maxillofacial and oral surgery, determined by the geographic location of the treating unit, disease patterns, availability of resources, expertise, and level of postgraduate training. The study was conceived to retrospectively evaluate the scope of pediatric maxillofacial surgery undertaken at the Wits Oral Health Center over a 5-year period. Oral surgery, pathology, trauma, and sepsis were the most commonly performed surgical procedures, whilst oncology and implantology were the least performed procedures. The majority of surgical procedures that were undertaken were done under general anesthetic in patients aged between 11 and 17. Wisdom tooth removal was the most common surgical procedure. A high occurrence of pediatric trauma in males, most commonly mandibular fractures, was observed in the same age group. Odontogenic keratocysts and ameloblastomas were the most common odontogenic cyst and tumors respectively. Present studies suggest that even though salivary gland tumors are uncommon in children, cystic lesions such as mucus extravasation cysts remain the most common salivary gland pathology. Notwithstanding its limitations, the study has added valuable data on the scope of pediatric maxillofacial and oral surgery. Information such as this is valuable in evaluating registrar training and level of exposure of trainees in pediatric surgery. Our recommendations include prevention strategies and educational campaigns targeted at the high-risk age group, which is 11 to 17 years, and must be informed by evidence accrued from studies such as this one. We recommend that prospective longitudinal studies be conducted to address the inherent deficiencies associated with retrospective studies, such as unavailability of records. In addition, consideration must be given for a streamlined electronic system, which can be used throughout the hospital to provide consistency with information and serve as a central data bank.
Good day. My name is Dr. M.G. Sehume. I am from Vet School of Oral Health Sciences, Department of Maxillofacial and Oral Surgery. I am going to present a case of Kaposiform hemangioendothelioma. Kaposiform hemangioendothelioma is a rare vascular tumor in infancy and early childhood, first described by Zuckerberg et al. In 1993. The tumor is derived from capillary and lymphatic endothelium with histologic resemblance to Kaposiform. Its rarity has prevented the development of optimum treatment guidelines and resulted in paucity of epidemiological studies. The tumor presents as a solitary blue-red lesion predominantly in the extremities, the trunk, and the retroperitoneum. It is uncommon in the head and neck region. Superficial and deep tissues are infiltrated by abundant vascular structures that form a tender mass. The tumor behaves aggressively locally and with no tendency for spontaneous regression, has a high recurrence rate but with no distant metastasis. High mortality rate when associated with Kaposiform phenomenon or syndrome. This syndrome is characterized by thrombocytopenia, consumptive coagulopathy, and purpura. Histologically, the tumor nodules with irregular borders is made up of spindled endothelial cells in fascicles. Immunohistochemistry shows positive vascular markers CD31 and CD34, positive lymphatic markers D2, 14, and negative for GLUT1 and human herpes virus 8. Mitotic figures are rare, there is no nuclear atypia, and there is no necrosis. The differential diagnosis would include infantile hemangioma, which involutes spontaneously venous malformations, infantile fibrosarcoma, and hemangiopericytoma. Biopsy is sometimes a challenge because of the coagulative nature of KHE patients. There is no consensus regarding therapy because of lack of prospective trial. Multimodal treatment approach is most common. Ablative surgery, the first line of therapy, preceded by embolization and sclerotherapy. Chemotherapy like vincristine, radiation therapy, steroid therapy, aspirin, propranolol, sirolimus are mostly used. Most patients receive multimodal therapy. I am presenting a case of an 11-month-old boy who presented to our unit with a swelling on the left side of his face. The swelling was of about a few months duration, was bony hard, was non-tender, and was about 1 centimeter of normal projection. Intraoral examination revealed swelling on the alveolar ridge on the same side of the mouth with mild buccal and lingual expansion. The overlying mucosa was normal in texture but with red hue discoloration. A decision was taken to have an incisional biopsy done, the results of which came back inconclusive. A few weeks later, the lesion had expanded by more than double its size, was extruding through the mouth with marked red hue on it. A decision was taken to embolize the feeding vessels and to surgically excise the lesion in full. This was done successfully with minimal bleeding. Curettage of the remaining bone was done, and the overlying and surrounding gingival tissues were also excised. Intraoperatively, minimal bleeding was encountered and was stopped successfully, and primary closure was achieved. On week 4 of review, the patient presented again with a 1 centimeter erythematous lesion in the area of previous surgery. The lesion was friable and bled easily. KHE recurrence was diagnosed and chemotherapy was commenced immediately by the Pediatric Oncology Department. Sirolimus 0.5 mg was given twice daily. The lesion was successfully managed over a period of 1 year with sirolimus 0.5 mg. On 1 year review, the patient is still tumor-free. Kaposiform hemangioendothelioma is a vascular tumor that presents in early childhood, and when associated with the Kasabach-Merritt phenomenon, the prognosis is poor. Multimodal therapy approach shows the need for evidence-based treatment protocols. This is the first case reported in the jaws treated by combined surgery and chemotherapy. Thank you.
Hello, my name is Dr. V. Prem Vyasa. Today I will be presenting a rare case, which is a Ewing sarcoma in an adult patient. Ewing sarcoma is the second most common primary malignant bone tumor in children after osteosarcoma. It belongs to the Ewing sarcoma family of tumors, which includes your Ewing sarcoma of bone, your extraskeletal Ewing sarcoma, your primitive neuroectodermal tumors, and your Askins tumors. There's a reciprocal translation between your chromosomes 11 and 22. This tumor represents 2% of childhood malignancies in the first 2 decades. There's a slight male predilection, especially in the extraskeletal prevalence, with 50% or more occurring extraskeletally. Clinically, pain, fever, and soft tissue swelling is most noticeable. The mandible is more affected than the maxilla. Radiographically, you find an irregular lytic bone-destroying lesion with ill-defined margins. There's also cortical destruction. The characteristic onion skin appearance occurs mostly in the long bones and is seldom seen in the jaw lesions. Management and prognosis of Ewing sarcoma requires a multidisciplinary team approach. Your current recommended treatment is combined surgery, radiotherapy, multi-drug chemotherapy. There is a 40 to 80% 5-year survival rate if managed early. Your poor prognostic indicators, however, are metastasis to distant sites spread into surrounding vital structures. Most frequent metastases are to the lungs, liver, lymph nodes, and other bone. I present a 27-year-old female patient with a main complaint that she had pain and swelling on the left side of her face, which was of 7 months duration. She also complained that she had this feeling that her eye was being pushed upwards. Medical history and dental history was of nil significance. Her special investigations included a computed tomography scan with soft tissue and bony windows of the head and neck area, positron emission tomography scan, which is your PET scan. She also had normal dental x-rays, which included an OPG. Then she had special blood investigations, which were the full blood count, and her urea and electrolyte levels were checked. She's also had an incisional biopsy done. The extraoral clinical exam revealed a swelling of about 4 by 2.5 centimeter swelling on the left side of the face, which was of a rubbery firm consistency, and the patient had pain on palpation. The swelling involved the left maxilla, the zygomatic, and the orbital areas. The overlying skin was of normal color, consistency, and texture. Intraorally, the patient had mild obliteration of the left buccal vestibule. There were no mobility of the left maxillary teeth. The mucosa was also of normal color and consistency on this left side. This is the frontal view of our patient in question. We note a swelling on the left side of the face. The left eye is being pushed upwards. Mind you, this is after receiving 6 months of chemotherapy, which has shrunk this tumor considerably. On the other side of our patient, we see a 3D reconstruction of a CT scan, which shows a lytic lesion that's involving the maxillary bones, the orbital bones, and the zygomatic bones of the face of this patient. These are the computed tomography scans, axial view, and coronal view with soft tissue windows. The soft tissue windows show us more the soft tissue detail of this tumor. As we can see as well in the bone, there is a lytic destructive lesion in the left side of the face. Histopathology normally reveals sheets or nests of small round blue cells with numerous mitotic figures separated by fibrovascular septa. This biopsy confirmed Ewing sarcoma of an adult patient. The treatment plan included chemotherapy for this patient, which she had received 3 cycles of chemotherapy. We had given her an operation date for the resection of the tumor. Our treatment comprised of actual surgery. The primary operation was done December 2019. The margins came back positive and the patient was reoperated in February 2020. However, on biopsy results, she still had positive margins. Therefore, the patient is currently undergoing radiation therapy and is on active follow-up in the department. These are intraoperative pictures at the primary surgery in December 2019. As we note on the left picture, the bone looks different from the frontal bone. And I'm talking about the tumor-infected bone. You can see it's much more red and swollen. This was resected, and in its place, we put in a titanium mesh, as you can see on the right side. This was to support the bone that we removed to keep the structure of the soft tissue and prevent the soft tissue from falling in. These are the post-operative pictures of the patient, frontal view and lateral view of the side of the tumor. This was taken in August of this year on her last recall to our maxillofacial OPD clinic. As we note, there is very good soft tissue contour. The soft tissue is supported on the left side of the face. However, we do note pigmentation on the left side of the face. This is due to the radiation that the patient has been receiving for the last 6 months due to having positive margins. The patient is doing very well, and we are following this patient up on a 3-month regular basis. In conclusion, I would like to say Ewing sarcoma is an uncommon aggressive tumor. It is very rarely reported in adults. Its early surgical intervention significantly reduces morbidity and mortality in these patients. Metastatic small cell carcinoma must be considered as a differential diagnosis of Ewing sarcoma in the adult population to ensure early and appropriate management of these patients. Thank you.
Well, that concludes the first 4 oral presentations, and I must say, I wish I was given a warning that there were going to be some graphic pictures. I'm not a medical person, so for me to see the things I've seen, shoo, I really take my hat off to every medical professional who is actually doing their best to ensure that our lives are secured. The research, the education, the development that goes behind the work that you do is very much commended. Let me give this opportunity to Professor Munjerere to comment on the first 4 presentations that we had.
Thank you very much. I would really like to thank the 4 presenters for wonderful presentations. Sorry, Patricia, for not warning you beforehand. I'm glad you are still standing.
My goodness, I almost actually passed out. I think we take it for granted, the work that you do, Professor, and along to all your colleagues. And more of education is needed for us lay people who don't deal with medical issues, because we really don't understand the magnitude of work that you do.
Thank you. So in the interest of time, I'm going to give very brief commentaries regarding all the 4 presentations in the order in which they were presented. The first one on needle stick injuries. Indeed, these are problems that we encounter. It's not only found in undergraduate that we're training, it can be found universally, although it decreases in the frequency or in the occurrence when you become more and more experienced in the career. The only thing we can do there is really to prevent these injuries. So by donning the proper PPEs, teaching the students proper techniques in terms of injecting and recapping of needles, also proper waste segregation that needs to be emphasized on. For those institutions that can, you can really indulge in buying disposable needles and syringes, and also there's more new technology in terms of injections. In terms of the second presentation, on the pediatric profiles of management of patients in MFOS, in maxillofacial and oral surgery, indeed we have seen that globally, the pattern looks almost similar. It's not surprising that the adolescents between 11 and 17, they're the ones who are showing up more in terms of maxillofacial and oral surgery. This is the age group that is hyperactive. They are very curious. They still want to, to dip their fingers into every area. Unfortunately, in their quest to know the world around them, they get injured. Then we end up treating them the most. What is worrying is that the temporomandibular joint disorders, they seem to be on the rise. One wonders whether it's because of the stressful life that the kids are subjected to, or whether it's the sedentary lifestyle that they are engaged in at this day and age. My comment on the third presentation on the Kaposiform hemangioendothelioma. This is really, indeed, a very rare condition. Fortunately enough, it's benign, which means it won't really just kill you summarily. However, it is very aggressive, and it's very rare to find it in bone. Many a times it presents as just a birthmark. That's what the lay person will see, is just a birthmark that's growing. But if it's fast growing like that and is associated with other comorbidities such as the Kasabach-Merritt condition or any other coagulopathy, unfortunately it can kill because these individuals, they end up bleeding a lot. Having said that, it means it's a management problem. You worry about the bleeding. Are you going to be able to control it? So there is no gold standard treatment that one can really engage in. You will treat the case as it comes. And for it to appear in the facial-skeletal region, it means management also is another challenge. So I commend the team, Professor Riccotto's team, that first did the embolization. They did the surgery, and then they followed up with some chemotherapy. Now, the last presentation on Ewing sarcoma. Indeed, this is a very rare cancer. Unfortunately, it's malignant, which means that it can go to other areas of the body and it can kill. And also, like the presenter has indicated, they couldn't get clear margins. It means they couldn't remove all the cancer. That is the problem in terms of its management. It is very rare in children. It is rare, according to the literature, it's rare in blacks and also in Chinese. I don't know why, but it is what it is. It is very rare in facial bones as well. It's rare in adults, and it's also very rare in the mandible. Now, they are reporting a case they found in the maxilla, which is even more rare. So, indeed, it's one of those rare finds. The question remains that I would like to ask the presenters. I know where to find them. I would like to know, because it's a very locally aggressive tumor, I would like to know if in this adult patient of theirs, if it was as aggressive as it is in the children. But I'll ask them when I meet them. Thank you.
Now you've posed the question that now we are all pondering, what is the answer? What is the answer? If the presenters are tuned in, please do send a WhatsApp at least, so we can know what the answer is before the end of the day, or else you'll leave a person like me itching the whole evening. The number for the WhatsApp is 064656 0131. We're going to move on to the next 4 groups of oral presentations, and after that, Dr. Ban is going to give us a summary of them.
Good day, everyone, and thank you for the opportunity to present my work, which is titled Validation of the Modified Oral Health Impact Profile Among Adolescents in Johannesburg.
Evaluation. Diabetes mellitus is one of the most common and major health problem worldwide in recent time. It is a metabolic disorder affecting carbohydrate, fat, and protein metabolism. It characterized by hyperglycemia with such symptoms as polyuria, glycosuria, and weight loss. It is the most severe forms. Ketoacidosis may develop and lead to coma, and in absence of effective treatment, death. Complication of diabetes mellitus is failure of several organs: heart, liver, kidney, bone, joint, mucous membrane, and nervous system. Micro and macrovascular complication and diabetic nephropathy, neuropathy, and neuropathy. Zamzam water. The Prophet Muhammad said the best water on the surface of the earth is Zamzam. In it, there is the food for the hungry and the cure for the ill. He also said, the water of Zamzam is the purpose for which drunk. It is different from other water in many ways. First, no bacteria can form at its source. Second, it doesn't go moldy, nor does it change color, taste, or smell. It's known to contain a wide range of therapeutic and pharmacological properties such as antioxidant, anti-tumor, anti-oxidative, and anti main nature of Zamzam water with average pH 8 is a potent antioxidant activity and anti-cancer effect, and it has known to protect DNA from. The material used in this study is Zamzam water from the Holy Mosque in Makkah al-Mukarramah, alexam monohydrate from Smu Iadr Pharmaceutical Company. First, the rat were fasted for about 20 hours before induction of diabetes. Then the rat injected intraperitoneal by alexam monohydrate 200 milligrams per kilogram body weight in a single dose, and then the blood collected from the vein and measured by glycometer and glucose test strips. The rats have fasting blood glucose level greater than 118 milligram per deciliter is considered as diabetic rat. Using hematoxin and iodine showing the control group of filiform papilla with conical shape and normal appearance. But in diabetic group, it is appeared with disturbance of the basal cell layer, and all the cell or most of the cells is vacuolated with eccentric nucleus, disrupted of the keratin layer, which is detached from the epithelium, and there is atrophy on all of epithelial cell layers. In Zamzam group, there is normal architecture of filiform papilla with continuous of the basal cell layer, and multiple mitotic cell division in all appears in all of epithelial cell layer, and normal arrangement of keratin. Electron microscopic result will showing it control groups, normal appearance of epithelial layers, and there is a basal cell layer with intact basement membrane and intact nuclear membrane and normal mitochondria appearance, and there is the hemidesmosomes, which is separating the basal cell from the underlying lamina propria. In diabetic group, there is appearance of multiple vacuolation in cytoplasm and vacuolated mitochondria, and there is no appearance of any intact hemidesmosome between basal cell and the underlying lamina propria. But in Zamzam water, there is appearance of intact mitochondria appearance, and the restoring of the appearance of multiple hemidesmosome with the underlying lamina propria. In spinoidal cell layer, there is for normal group, and here for diabetic it is multiple vacuolated and the loss of the boundary of the cell and the vacuolated mitochondria, and some of them undergo apoptosis. In Zamzam group, restoring of the cell boundary and multiple desmosomes junction will appear between the. In normal group, control group, the normal stratum corneum is appeared with normal keratin squamous and keratohyalin granules in granular cell layer. But in diabetic group, there is irregular keratin layer and the remaining of brachial cell layer after its apoptosis, and density of keratohyalin granules will be appeared. But in Zamzam water group, interdigitation between granular cell layer and the obvious electron dense keratohyalin granules is occurred, and there is interdigitation between normal interdigitation restored between a granular cell. Conclusion: Zamzam water provides safer alternative nutritional strategy in restoring the integrity of the damaged tongue tissue epithelium and the configuration of all layers of epithelium after degenerative effect of diabetes mellitus. Further researches in the future on the potential power effect of Zamzam water upon different damaged tissues are recommended.
Good morning everybody. I am Kannan Natarajan, PhD Research Scholar from Lincoln University College, Malaysia. Today I will be sharing about my double-blinded randomized control trial comparing virgin coconut oil with artificial saliva in improving quality of life in patients undergoing radiation therapy for head and neck cancer. As you are aware, head and neck cancers are on the rise across the world. Radiation therapy is one of the most commonly used treatment modalities and is usually administered in the form of teletherapy. The dosage is given as about 200 centigrade once daily, referred to as fractionation, or 100 centigrade twice daily, referred to as hyperfractionation. Radiation therapy can affect cells directly by damaging the biomolecules and the bond between the DNA helixes and damage to the nuclear and the cellular organelles. In the indirect effect, there is radiolysis of water molecules leading to generation of reactive oxygen species, which goes and damages the cellular organelles. Coming to common complications of radiation therapy, these include radiation mucositis, candidiasis, trismus, loss of taste, salivary alterations in the form of xerostomia, reduced pH, increased viscosity, reduced lubrication, and reduced buffering capacity. This study done by me was approved by the Institutional Ethical Committee. Permission for use of the Quality of Life questionnaire was obtained from URTC. The trial was registered with Clinical Trials Registry of India. The topic was registered and approved for PhD thesis by Lincoln University College of Malaysia. For purpose of randomization, computer generated block randomization was done and patients were allocated to study group receiving virgin coconut oil and control group receiving artificial saliva containing 80 participants each. Patient informed consent was obtained and virgin coconut oil and artificial saliva were packed in identical containers which were dispensed appropriately by the clinical research assistants. Patients were instructed to switch their mouth with 5 ml of the medication for 2 to 3 minutes, then spit it out, QID, for the entire duration of the radiation. Quality of Life questionnaire was administered at the end of every week of radiation therapy, and the degree of radiation mucositis was recorded along with photographic documentation of it. This is the clinical photograph of patient who was put on virgin coconut oil therapy at the end of 5th week of radiation therapy. This is a clinical photograph of patient who was administered artificial saliva at the end of 3rd week of radiation therapy. This is a patient who was requiring nasogastric feeding because of inability to have oral alimentation. The mean pain score at the end of 6th week in the control group was 406 and in the study group it was 292. Mean score of swallowing at the end of 6th week in the control group was 366 and in the study group it was 236. Sensation problems at the end of 6th week in the control group was 184 and in the study group is 135. Mean score of speech problems in the control group at the end of 6th week was 293 and in the study group it was 227. Social eating problem score at the end of 6th week in the control group was 377 and in the study group it was 367. Social contact problem at the end of 6th week in the control group was 425 and in the study group was 362. Sexual problems score at the end of 6th week in the control group was 222 and in the study group was 230. Mouth opening problem in the control group at the end of 6th week was 31.25 and in the study group was 23.58. Dental problems at the end of 6th week in control group was 24.99 and in the study group was 22.91. Dry mouth score in the control group at the end of 6th week was 19.6 and in the study group was 12.72. Sticky saliva score at the end of 6th week in the control group was 58.82 and in the study group was 29. Mean score of coughing, both the groups was equal, 50.98. The patient feeling of illness in the control group at the end of 6th week was 70.58 and in the study group it was 54.5. The need for use of feeding tube in the control group was 35.9 and in the study group was 15.94. Mean score of weight loss in the control group at the end of 6th week was 64.70 and in the study group was 35.29. None of the patients had any weight gain. Coming to discussion, virgin coconut oil has proven anti-inflammatory, analgesic, antifungal, antimicrobial, lubricant and antioxidant properties. Review of literature showed only one clinical trial using virgin coconut oil, referred to as VCO PRIM study, done by MC Cruz in 2014 in patients with nasopharyngeal neoplasms, has shown benefit in the patients who are receiving virgin coconut oil. We have published a study on antifungal activity of virgin coconut oil in International Journal of Phytotherapy in 2014. Coming to summary, the scores of symptoms were significantly low in study group as compared to control group. Radiation mucositis scores were less in study group as compared to control group. Patients receiving virgin coconut oil reported less discomfort and better quality of life than those receiving artificial saliva. 10% of the patients receiving virgin coconut oil were not comfortable with its taste. Coming to conclusion, virgin coconut oil is better than artificial saliva in ameliorating the signs and symptoms of complications due to radiation therapy. Multicentric trials can be planned so that virgin coconut oil can be instituted as regular protocol in head and neck cancer patients. Thank you.
Welcome to a case report on Fibrodysplasia ossificans progressiva. Fibrodysplasia ossificans progressiva is an extremely rare heritable disorder of connective tissue metamorphosis, characterized by congenital malformation of the greater toes and progressive postnatal heterotropic ossification of skeletal muscles, tendons, ligaments, and fascia. FOP occurs due to heterozygous genetic mutation in the activin A receptor type 1, a bone morphogenic protein type 1 receptor signaling endochondral ossification. The international incidence of FOP is reported to be 1 in 2 million people. This genetic mutation in the activin A receptor type 1 results in the signaling of endochondral ossification, which results in the induction of extraskeletal bone formation called heterotropic ossifications. These ossifications usually involve muscles, tendons, ligaments, fascia, and aponeurosis. Okay. The heterotropic ossification is often preceded by soft tissue swelling with heat and pain, colloquially referred to as flare-ups. These flare-ups can either be spontaneous or as a result of traumatic soft tissue injuries such as biopsies, intramuscular injections, or mandibular nerve blocks. Okay? This results in ossifications occurring around the joints, in the joints, and around the joints, resulting in joint limitations, growth defects, and skeletal deformities. FOP is diagnosed clinically by the occurrence of soft tissue swelling lesions with bilateral malformation of the greater toes. Congenital hallux valgus with macrodactyly and a monopharyngeal great toe in children should be considered as an early diagnostic sign for FOP even before the onset of mass lesions. Confirmatory genetic analysis of ACVR1 mutation is available on a clinical and research basis at some laboratories in South Africa. Due to the similarity nature of the disease and its rarity, FOP is often misdiagnosed as fibromatosis, cancer, myositis, ossificans, arthritis, and rheumatic heart disease. Often this misdiagnosis results from the failure by clinicians to associate deformities of great toes and rapidly developing soft tissue swellings appearing on the head, neck, and upper back. This misdiagnosis is understandable given the rarity of the disease. A 6.5-year-old girl presented to the Chris Hani Baragwanath Academic Hospital Maxillofacial and Oral Surgery Unit with a chief complaint of progressive stiffening of her joints and subsequent severe restriction in mouth opening of 2 years duration. The patient had a history of restricted movements of her arms and neck. She had swellings involving the neck, shoulders, and over the back, which began when she was 4 years of age. She consulted a regional hospital, which then referred her to our institution with a differential diagnosis of myositis ossificans. The patient did not present with any medical or dental history of significance other than the history of an acute soft tissue flare-ups, which were treated at another tertiary hospital. Details of this treatment was not documented. She reported that the flare-up started spontaneously on the back of her neck and extended over the head. Since then, she noticed the bony exostosis and limited joint movement, especially on the shoulders and temporomandibular joints and elbows. A 6.5-year-old girl presented with a weight of 20 kgs, height of 122 centimeters, and head circumference of 55 centimeters. The patient presented with a prominent occiput and restricted mouth opening to about 5 millimeters due to the stiffness of the temporomandibular joints. A pectus excavatum deformity was noted on the chest. Multiple bony hard lumps were noted on the chest and at the back in the posterior thorax. The fingers appeared long with bilateral clinodactyly of the 5th digits. The halluces were laterally deviated and short. Severely restricted range of motion in the elbow joints, temporomandibular joints, left knee joint, and limited flexion of the spine were noted. The cardiovascular system, abdomen, female genitalia, and skin examinations were normal. Lateral skull and cervical spine radiograph revealed bony formation between occipital and spinous processes of axis and 3rd cervical vertebra. Interspinous ligament ossification spanning between axis and cervicothoracic junction was also noted. Anterior-posterior chest radiograph showed linear ossifications along the lateral chest wall surrounding both scapula. Also visible on this view were ossifications around the right elbows. Lower limb radiographs displayed ossification on the femoral and tibial condyles. Based on the history, clinical and radiographic findings, and after consultation with a medical geneticist, a diagnosis of FOP was made non-invasively. Subsequently, a decision for non-surgical management was made. FOP ossifications normally begins in the neck, spine, and shoulder girdle. Congenital hallux valgus with macrodactyly and monopharyngeal great toe is an early diagnostic tool. Intramuscular injections must be avoided, and any invasive surgical procedures should also be avoided. Great care is necessary in administering dental care. Dental management of patients with FOP continues to pose a problem for many dental practitioners around the world. This is directly related to the restricted mouth opening associated with temporomandibular joint ankylosis or joint stiffness and ossification with the muscles of mastication. Maintenance of a meticulous oral hygiene becomes increasingly difficult as the mouth opening deteriorates and due to decreased manual dexterity. The risk of exacerbating the extraskeletal ossification process during routine dental treatment requiring local anesthesia administration is also a problem. It is therefore imperative that patients with FOP be subjected to the necessary precautions in the prevention of oral disease and the maintenance of a healthy oral environment. This includes the use of fluoride toothpaste, fluoride gels, chlorhexidine mouth rinses, frequent flossing, and brushing. Preventive oral and dental health care measures are essential. In patients with TMJ ankylosis, special toothpaste and fluoride rinses may be the most practical method. Prevention is important in FOP as currently there is no definitive treatment modality. The current treatment of FOP focuses on the symptomatic relief of acute flare-ups rather than treating the condition directly. This involves the use of steroids and non-steroidal anti-inflammatory drugs. Local anesthetic infiltration into the periodontal ligament or pulp cavity is considered safe, but intramuscular injections must be avoided and routine venipuncture must be performed with care. Caution must be exercised when administering dental care, particularly in avoiding overstretching of the jaw. General anesthesia with nasotracheal fiber optic intubation is recommended and forms an integral part in the management of patients with FOP requiring invasive and urgent dental treatment. FOP is a rare autosomal dominant inherited genetic disorder of connective tissues caused by mutations in the gene encoding for ACVR1, a bone morphogenic protein type 1 receptor. The two defining clinical features of FOP are congenital malformation of the greater toes and progressive heterotropic ossification. Through correct diagnosis, counterproductive surgery was avoided in this case. This case also highlights the challenges and critical decision-making process in a multidisciplinary forum in the management of FOP patients with oral health problems. Importantly, it underscores the value of early and correct diagnosis of FOP in preventing iatrogenic harm to these patients through unnecessary diagnostic or surgical procedures. The rarity of these lesions, particularly in the maxillofacial and oral surgery region, justifies presentation of this case to increase awareness amongst clinicians. With this information, dentists in particular can take the necessary precautions in the prevention of oral disease and maintenance of meticulous oral hygiene in these cases. Welcome to a case report on Fibrodysplasia ossificans progressiva.
Good day. The title of my presentation today is Implementation Fidelity of School Oral Health Programs in Tshwane, and my name is Dr. Mpho Molete. As we may all be aware, school children continue to experience high levels of dental caries, and this impacts on their quality of life because it causes loss of school days and poor school performance. Hence, school oral health programs facilitate learning and address health barriers to learning. Although there are many programs that are running across the country in South Africa, there still persists high levels of untreated dental caries that has not been resolved. Literature suggests that for successful implementation, programs need to be monitored through stages of design, development, and implementation in order that accurate interpretations of how the program contributes to the desired outcomes can be made. And therefore, such deductions are made possible by the concept of fidelity, which actually refer to the application of an intervention as originally designed. And therefore, in understanding the design and processes leading to a successful program, it provides us with evidence that can be documented and assist in guiding us in how to strengthen a particular program. And therefore, a program with high fidelity would therefore be considered to produce favorable outcomes. The aims of my study were to therefore assess the extent of implementation fidelity at school oral health programs in the district of Tshwane, and the specific objectives included to assess the level of fidelity achieved, determine how elements of fidelity predict the risk of decay, and determine how potential moderating factors interact with fidelity in predicting the risk of decay. In terms of methodology, the study was a cross-sectional analytical design where all the 10 oral hygienists providing services in schools in Tshwane were invited to participate. What we did was then we randomly sampled one school from each of the hygienist lists, and all the schools that were selected have had to have been operational for over a year. And then in terms of selecting the learners, a multi-stage sampling technique was used to randomly select 10 schools. Then in each schools, 2 grades were selected, either grade 1s and 7s or grade 1 and 6, depending on the sizes of the school. And therefore, all learners with written consent in the selected grades received an oral health examination. Besides an oral health exam that was undertaken on the learners, a fidelity checklist was utilized in order to guide the observations that were conducted as the oral hygienists were working with the children at the schools. And the key measurements of the fidelity checklist included adherence and moderator elements. The adherence elements included the content, coverage, frequency, and duration, and the moderator elements included quality of delivery, facilitation strategies, and participant responsiveness. Now, quality of delivery referred to the manner in which the program was carried out, and facilitation strategies referred to factors that existed to optimize fidelity, and participants' responsiveness referred to oral hygienists, teachers, and parents' engagement with the program. Okay, now the key results of the study revealed that 28% of the content was covered by the oral hygienist, that the proportion of learners that were exposed to the program were over 100%, that the fidelity level was 39.6%, and the mean decay score was 0.54. And on the right, we see the margin plot, which actually demonstrated that as fidelity increased, decay decreased. And this is in line with the fidelity principles that suggest that the higher the fidelity, the better the health outcomes. In terms of the results concerning the relationship of fidelity elements with decay, we see here that duration and coverage were predicted to reduce the risks of decay, whereas the content and age were predicted to directly increase the risk of decay. For moderating effects, as they interacted with fidelity, they were predicted to reduce the risks of decay, particularly the facilitating strategies of having some chairside assistance, and also duration in terms of spending more time at the schools. Moreover, we see that age comes up again, that when age interacts with fidelity, it is predicted to reduce decay. And again, this is in line with the fidelity principle. In conclusion, the extent of implementation was 40%, which was low. Therefore, there is a need to improve implementation fidelity in the districts. And the following recommendations have been put forward. that there needs to be training of oral hygienists on policy objectives. Number 2, that there needs to be some agreement on key program components and also the use of process mapping tools in order to guide implementation. And thirdly, that there needs to be an exploration of the integration of community health workers in supporting oral hygienists with school oral health programs. These are my references. And thank you for listening.
I'd like to ask Dr. Ban to please give us her commentary. Seems like there's still one more. I'm not sure if the technical team is aware, but we've gone through all 4 of the presentations under Dr. Ban. Perhaps the ones that you are looking at are falling under Professor Situsa. So can we please just go ahead and allow Dr. Ban to do her commentary. Dr. Ban.
Thank you. Good afternoon, everyone, and thank you for the opportunity to be here. And I would like to first start off by saying thank you and well done to the presenters in this category. It was certainly quite a diverse array of lesions and pathology that was presented here. So, in the interests of time, just as Prof. Munzelele had said, I'm just going to give commentary per presentation as in the order that they presented. The very first study, I must say, was quite fascinating to me because I had no idea what Zamzam or Zamzam water was. So I had to do a search to find out what this was and what magical healing properties it had. And it then it became apparent that this water can only be obtained from a specific spiritual well in Mecca, and that it has got phenomenal healing properties. So the research project for me is exceptionally detailed, and I wanted to find out the reason for the choice of rat species or the reason for the choice of albino rats used in this particular study, and also that you need to control the studies with histology from the start right through to the end so that you can compare and see if there are real changes or not. Just speaking from a layman or from a normal point of view and perspective, it would be quite interesting if this did serve to be true, where we would be able to get this Zamzam water. Is it readily available? We all don't do tours to Mecca, so it must obviously have to be brought in somehow. And the other interesting thing that I read in other literature, which was not included in the presentation, is that much of the Zamzam water that is used is highly toxic. It contains many arsenical compounds. So I'm not too certain how magically healing it can be or may be to some individuals. But nevertheless, the presentation was very interesting and exciting.
Dr. Ban, I just want to ask you on that note of the healing properties of water bodies, and obviously basing it on the fact that we've heard that the River Nile has some healing properties, some waterfalls in Ethiopia have healing properties. Do you think that we could ever get to a point where medical research would actually go into these water bodies and look if the Dead Sea can really, have those healing properties? Can this Zamzam water have healing properties to possibly stop us from using conventional medicine and using what is already there's healing elements?
Yes, I think these are all natural sources of water. And I mean, when I was speaking about toxicity with the arsenical compounds, we must remember that our own water system, that our tap water that we drink, is regarded by many as being toxic for all the additives and fluoride that we find in it. So I do think that it would be worth study of these various different bodies of water and the properties and their constituents and how the effect that it would have on the body and physiology. Yeah, most definitely. The second presentation was with regards to radiation mucositis and the use of artificial saliva versus what they used as virgin coconut oil. This also grabbed my attention because several years ago it was widely reported in the media that there was this global trend of what is called oil pulling. Oil pulling is where people make use of coconut oil specifically. Some choose to use olive oil or other types of oil, and they pull it through between the teeth, rinse the mouth out, and spit it out. And there is widely documented evidence of many healing properties as well as tooth whitening attributed specifically to the use of coconut oil. So I remembered this, and then I saw this presentation and I thought, wow. Used in the context of radiation mucositis is a very debilitating disorder that occurs in all patients who have been treated for some form of head and neck malignancy. The salivary glands become fibrotic, the glands tend to shrink, and they don't have enough or adequate saliva production. And this definitely has a decrease, or it really does affect the patient's quality of life. I think that it would be worth exploring the use of natural alternatives when it comes to any healthcare situation, and I think that is what we are striving for if we think that we want to achieve holistic patient health and well-being. We should be exploring all options that are available to us. Then for the third presentation, Fibrodysplasia ossificans progressiva. This is an exceedingly rare genetic condition, and I have never had the opportunity of diagnosing or being part of a team to diagnose such a condition. So that is extremely rare and a very good point for awareness. Also, the disease causes severe debilitation in patients who have it. And if you look at the lifespan of these patients, it's usually in the mid to upper 50s. So they generally live a long time with a very bad disease. And they therefore do need a lot of treatment, and the earlier this is diagnosed, the better the treatment process will be for them and the less painful it will be. And so therefore it is important that our oral healthcare workers be aware of such rare lesions in case they do come across them, and how to limit pain and further distress and disease for the patient. Then for the fourth program, it is for me quite sad to see that we do have such a desperate lack of oral health care, particularly in our schools and in younger individuals in this country, and I think it is something that needs to be highlighted. There needs to be a national drive for oral health care services and for more oral health care workers to be made available in the public sector. And just as if one part of the body is sick, the entire body is sick, you cannot neglect the oral cavity. And it is a source of great distress to many students, the cause of loss of time and tests and work, and it desperately needs to be addressed. So, great.
Thank you very much, Dr. Ban. Now it's time for us to look at 6 other oral presentations. Let me remind you that our WhatsApp line is still open if you'd like to ask questions or give comments on these presentations. The number is 064-656-0131. We have also put up the poster presentations that we'll come to a bit later. And if you'd like to view them right now, you can do so at www.smu.ac.za/IADR/2020. Let's go to the next presentations, of which Professor Situsa will be giving us commentary afterwards.
The title of my research is The Analysis of Malocclusion. Planning orthodontic services within a public health system may require some information on the prevalence and distribution of malocclusions. The majority of studies which focused on the prevalence of malocclusion were conducted in the 1970s, and then later studies focused more on the treatment need. According to the World Health Organization, epidemiological studies are still relevant today, and they further recommend that these studies should be conducted on a regular basis. After an intense search of the literature, we found that malocclusion is present in all populations, but its prevalence certainly differs in different parts of the world among various populations. These variations are attributed to various ethnic, genetic, and environmental factors which may influence the prevalence and distribution of certain malocclusion traits. No data on the prevalence of malocclusion is available for the population of the Free State Province. Hence, the purpose of this study was to analyze the distribution of malocclusion and its associated characteristics in the referred Free State orthodontic patients. The aim of the study was to determine the distribution of malocclusion and its associated characteristics in a population of patients referred to Pediatric Hospital of the Free State Province. The study had 3 objectives, and the first objective was to determine the distribution of malocclusion in the referred Free State orthodontic patients. The second objective was to determine the gender distribution of malocclusion in the referred Free State orthodontic patients. And the third objective was to determine the distribution of malocclusion traits that are found in the referred Free State orthodontic patients. Our study population comprised of orthodontic records of all the patients who were referred to the orthodontic clinic of Pediatric Hospital in Bloemfontein. These records were of patients who were referred from the 1st of January in 2012 to the 31st of December in 2018. And this is the period during which I was employed at that particular hospital. The records included the hospital files and the study models. Ethical clearance to conduct the study was granted by the Biomedical Research and Ethics Committee of the University of the Western Cape. No sample size estimation was calculated for this study, as we had planned to include all the records of patients which satisfied the inclusion criteria during the specified period. Our sampling method was a convenient sampling method where we selected the subjects to participate in the study as they came. After applying careful inclusion criteria, we were then left with a sample of 391 subjects who were included in this study, of which 235 of these subjects were female and 156 were males. And the mean age of this selected sample was 15.4 years. The age of the subjects in the study, they ranged from 6 to 35 years, with a mean age of 15.4 years. Among the 391 subjects that participated in the study, 14.1% of the subjects were of the age group 6 to 11 years, and then 61.4% of the subjects were of the age group 12 to 17 years, and then 18.3% of the subjects were of the age group 18 to 23 years, and then 5.1% of the subjects were of the age group 24 to 29 years, and only 1.1% of the subjects were of the age group 30 to 35 years of age. The highest number of patients was found in the 12 to 17 years age group, while the lowest number of patients was found in the 30 to 35 years age group. Then female subjects were more frequently represented in all the groups, all the age groups for the total sample. This graph represents the distribution of English malocclusion for the total sample. And once again, female subjects were more frequently represented in all the 3 classes of malocclusion. We see a similar pattern of distribution of malocclusion in all the age groups, with class 1 taking the lead, and this is followed by class 2, and then class 3 being the least represented in all the age groups. The two graphs that you see represent the distribution of overjet and overbite for the total sample broken according to age. The highest number of subjects with a normal overjet was recorded in the 12 to 17 years age group, and the lowest number of subjects was recorded in the 30 and to 35 years age group. The highest number of subjects with a large overjet was recorded in the 12 to 17 years age group, and the lowest number of subjects with a large overjet was recorded in the 24 to 29 years age group. No subject was found to have a large overjet in the 30 to 35 years age group, and then the highest number of subjects with a reverse overjet was recorded in the 12 to 17 years age group, and the lowest number of subjects was recorded in the 30 to 35 years age group. Normal overbite was observed to be the most common vertical occlusal characteristic recorded in the sample. The highest number of subjects with normal overbite was recorded in the 12 to 17 years age group, and the lowest number of subjects was recorded in the 30 to 35 years age group. Deep overbite was the second most common vertical occlusal characteristic in the sample, with the highest number of subjects with a deep overbite recorded in the 12 to 17 years age group, and the lowest number of subjects with a deep overbite recorded in the 24 to 29 years age group. No subjects in the 30 to 35 years age group was found to have a deep overbite. The other vertical occlusal characteristics that was recorded in the sample was an anterior open bite, and this was the third most common vertical occlusal characteristic that was recorded. The highest number of subjects with an anterior open bite were recorded in the 12 to 17 years age group, while the lowest number of subjects was found in the 30 to 35 years age group. The subjects exhibiting an edge-to-edge relationship of the incisors were the least commonly recorded occlusal trait in the sample. The highest number of subjects with edge-to-edge relationship of the incisors, these were recorded in the 12 to 17 years age group once again, with the lowest number of subjects being recorded in the 18 to 23 years age group, and also in the 24 to 29 years age groups. Once again, no subject in the 30 to 35 years age group was found to have an edge-to-edge relationship of the incisors. The highest number of subjects with anterior crossbite was recorded in the 12 to 17 years age group, and the lowest number of subjects was recorded in the 30 to 35 years age group. The highest number of subjects without anterior crossbite was recorded in the 12 to 17 years age group, while the lowest number of subjects was recorded in the 30 to 35 years age group. The highest number of subjects with posterior crossbite were recorded in the 12 to 17 years age, and the lowest number of subjects was recorded in the 30 to 35 years age group. The highest number of subjects without posterior crossbite were recorded in the 12 to 17 years age group, while the lowest number of subjects was recorded in the 30 to 35 years age group. This graph represents the distribution of incisor crowding and the degree of treatment need for the total sample, as this was determined by the dental health component scores of the index of treatment need. Among the 391 patients examined, the distribution of the DHC scores for little or no incisor crowding was the least common observation, and this was followed by the moderate incisor crowding, and the most frequently observed dental health component score was for the severe incisor crowding group. The highest number of subjects with no or little incisor crowding was recorded in the 12 to 17 years age group, and the lowest number of subjects was recorded in the 30 to 35 years age group. The highest number of subjects with moderate incisor crowding was recorded in the 12 to 17 years age group, and the lowest number of subjects was recorded in the 24 to 29 years age group. The highest number of subjects with severe crowding of the incisors was recorded in the 12 to 17 years age group, and the lowest number of subjects was recorded in the 24 to 29 years age group. The result of the study confirms data from other studies that there is a universal pattern of distribution of malocclusion globally. The majority of the subjects in the study presented with a class 1 malocclusion, followed by class 2 and then class 3 malocclusion respectively. These results are similar to the results of many other studies which were conducted in other parts of the world. Although the majority of subjects in the present study had a normal overjet, 30% of our sample had large overjets of between 4 to 6 millimeters, and only about 0.7% of the subjects had excessive overjet of more than 7 millimeters. Many clinical studies have shown that excessive overjet is a risk factor for trauma and gingivitis, which can predispose a patient to periodontal breakdown. And for this reason, these patients should be prioritized when planning orthodontic services in our hospital. The majority of subjects in the study had a normal overbite, and a deep bite was recorded as the second most common vertical finding, and this finding was consistent with other studies elsewhere, especially in the African countries. Deep bite is another malocclusion trait that must be treated because it carries the risk of tissue impingement, which can often lead to periodontal breakdown. Anterior open bite was the least common finding in the study. However, this malocclusion, if it is diagnosed, it should also be treated as it may be associated with speech problems and also with the mouth breathing habits. Anterior crossbite was the most common finding, and this was also consistent with the results of the other African studies. Crossbites should also be treated early because they can cause the jaws to shift to one side as the patient tries to find a comfortable biting position, and this can result with a lopsided growth of the face. If the crossbite is left untreated, this can also develop into a true clustering malocclusion, which may be very, very difficult to treat. The majority of our patients in our study had severe crowding of the incisors, and according to Daniels and Richmond in 2000, incisor crowding is the most common reason for patients' dissatisfaction with facial appearance, which, if not treated, this can result in depression, anxiety, and also low self-esteem. This study unfortunately also suffers some limitations. The sample used in the study was selected from a Free State population of patients that were specifically referred to Orthodontic Clinic of Pediatric Hospital, and for this reason, the sample that was used in the study is not representative of the entire population of the Free State province. Now, having said that, if anybody wants to use the results of this study, we recommend that they exercise extreme caution because purely for the reasons that the sample was not representative. And then in the strictest sense, this study is only comparable to other research that was conducted using the same measuring or registration criteria. For example, in a study that, done by Konz et al., and also in another study that was done by Kunzel and Blattner, amongst other studies, of course. We also wish to state that congenitally missing teeth, impacted teeth, and some of the missing teeth due to extractions or trauma, in the same population, they were not reported. And this is another limitation of the present study, which was acknowledged or which was stated by Ume in 1973. And Heinkenmo in 1978, he further suggested that occlusal traits that are observed or measured on the study models, they tend to reflect a higher prevalence of deviations than when a direct intraoral examination is done. In other words, what he was saying is that the measurements on the study models can tend to be over-exaggerated sometimes. In conclusion, the most prevalent malocclusion in the Free State referred patients, it was recorded as class 1, and this was followed by class 2, and then the least commonly recorded malocclusion was class 3. The most common occlusal characteristics that were recorded in the study were increased overjet, deep overbite, anterior open bite, and also the posterior open bite. The majority of the subjects in this sample required a great or severe treatment need, and these were followed by the subjects who needed moderate need of treatment, and the least number of subjects in the sample required little or no treatment, and this was according to the dental health component scores of the IOTN. The author wishes to state that this study was not supported by any research grant, and we declare that the study has no conflict of interest. I want to take this opportunity to thank you for your attention, and at this point in time, I would welcome some questions from the floor. Thank you very much.
day, everyone. The title of my research is Radiographic Comparison of Mandibular Symphysis Dimension in Patients with Different Skeletal Patterns. Orthodontic treatment often involves planned tooth movement within the confined spaces of the alveolar bone trap. The mandibular symphysis limits tooth movement due to thin labial and lingual cortical plates and also narrow alveolar trap. Moving lower incisors beyond the mandibular symphysis dimensions may result in damage to the roots and alveolar bone. To give the brief description of the abbreviations that I'll be using in my presentation, we've got LA, which is bone labial or anterior to lower incisor apex, LP, which is bone lingual or posterior to lower incisor apex, LH, which is the bone inferior to lower incisor apex. LA plus LP is the total bone width. In 2010, Crago et al. Did a study in Italy to investigate correlation between the shape of mandibular symphysis in various facial types. He reported that short-faced subjects presented with thicker mandibular symphysis dimensions than long-faced subjects. In 2014, Maniyar et al. In India compared lower incisor compensation and morphology of the mandibular symphysis in adult subjects with skeletal class 2, 3, and skeletal class 1. The findings was that subjects with skeletal class 2 or 3 had narrower mandibular symphysis than subjects with skeletal class 1. They also reported that skeletal class 3 subjects presented with high and narrower symphysis, extruded and retroclined lower incisor, increased LP and decreased LA and LH, whereas subjects with skeletal class 2 presented with extruded and proclined lower incisors, as well as decreased LP and increased LA and LH. In 1996, Handelman did a study in Chicago to establish cephalometric norms of mandibular symphysis dimensions of lower incisors. In his findings, he reported that LH was longer in class 3 than in class 1, LP was narrower in class 3 than in class 2 skeletal pattern or class 1 skeletal pattern, and LA, LP, LA plus LP were thicker in short-faced subjects than in average or long-faced subjects. The aim and objective of our study was to determine and compare the norms of mandibular symphysis dimensions in subjects with different skeletal patterns to determine whether the above findings were stratified by gender differences. The methodology of my study comprised of adult patients aged 18 years and older, 180 cephalometric radiographs that were equally distributed according to gender and skeletal patterns, and they were further subdivided according to facial types, and the data was analyzed using SAS version 9.4 software program. Our results indicated that the bone labial to lower incisor apex was thicker in class 1 and class 3 than in class 2 subject. And in skeletal class 1 subject, the bone labial to lower incisor apex was thicker in females than in males. And in skeletal class 3 subject, the bone inferior to lower incisor was longer in males than in females, whereas in skeletal class 1, LH was longer in females than in males. And also our results indicated that LH was shorter in short-faced subjects and longer in long-faced subjects. So this study correlates with that of Handelman in 1996. Our conclusion is that caution should be exercised when treating subject with long face and also when treating subject with thinner LA, which is the skeletal class 2 subject and skeletal class 1 males, and also when treating subject with long and narrow LH, which is found in skeletal class 3 males and in skeletal class 1 females. This is some of the references that were used in our study. Thank you.
Hello and greetings from the Department of Orthodontics, Makato University. My name is Dr. Elizabeth Thomas and I will be speaking about my study that is called The Characteristics and Complications Associated with Supernumerary Teeth, a Radiographic Study. Supernumerary teeth are teeth formed in excess of the normal complement of teeth. Malocclusions caused by SNT affect the aesthetics, mastication and speech of children and impact negatively on their self-esteem. Therefore, early detection and management of SNT are crucial in avoiding these problems. A review of literature revealed that there was limited data about the prevalence and distribution of SNT in South Africans. The only study that was conducted by van der Merwe and Steen in 2009 was on skeletal remains. Therefore, it was felt a need to increase awareness and create an understanding of this anomaly in a cross-sectional living sample of Black South Africans. There are many diagnostic aids available in orthodontics. We have the panoramic radiographs, we have the lateral cephalogram and the periapical radiographs. Out of all these three, SNT are usually found when we take panoramic radiographs for diagnostic purposes. Accordingly, it was decided to conduct a study analyzing panoramic radiographs of dental patients. The aim of the study was to determine the characteristics and distribution of supernumerary teeth in Black South African dental patients and catalogue orthodontic complications, if any, associated with this condition. Objectives of the study were divided into Part 1 and Part 2. Part 1 was concerned with the distribution of a number of SNT per patient, the morphology of SNT, and also to locate the position of SNT in the jaws. Part 2 was to assess the eruption status of the SNT, to establish the relationship between eruption status and morphology, establish relationship between eruption status and orientation of SNT, and also to catalog orthodontic problems, if any, associated with this condition, like displacement, spacing, impaction, or any other effect on the adjacent permanent teeth. Criteria for selection into this retrospective cross-sectional radiographic study was that each patient should have had a panoramic radiograph taken for diagnostic purposes. The radiograph had to be of good quality and portray the dentition and the structures clearly. The age range of the subjects was to be from 3 years to 40 years of age. The subjects should be free from syndromic disorders and should be of Black ethnicity. Thus, a sample of 298 patients with 473 SNT was obtained after analyzing 12,005 panoramic radiographs. Data analysis of the results showed that distribution of SNT did not reveal any significant sexual dimorphism, but females were found to have a higher number of SNT per person. However, this was not a statistically significant finding. SNT were tabulated according to 4 different types of morphology as supplementary, conical, tuberculate, and other. The other was a category when the researcher could not determine the shape was coinciding with any of the 3 categories mentioned above. It was found that supplementary was the most common shape. It was found that the maxillary jaw had a higher predilection for SNT. When comparing the distribution of SNT in the anterior premolar and molar regions, it was found that the lower premolar region had a significantly higher incidence of SNT compared to the maxillary premolar region, and that this condition was reversed in the molar regions. It was also found that 27% of the SNT had an eruption status, while 72.94% were unerupted. Conical SNTs had a higher chance of eruption, as was vertically oriented SNT compared to SNT that were inverted in position or oblique in orientation. Regardless of the eruption status, SNT was found to cause orthodontic problems, and displacement and impaction of adjacent permanent teeth were the most significant. It is hoped that the results of the study and the problems catalogued will help the clinician in the diagnosis, timing, and treatment planning of affected individuals. In addition, due to the increased incidence of SNT in the mandibular premolar region, caution is advised when planning the placement of implants for anchorage reinforcement in this population group. These are the references. Very much.
For today is prevalence of malocclusion amongst school children in Sediment District, Gauteng Province. Malocclusion traits vary between individuals, age groups, and among ethnic groups. Knowledge of a population's epidemiological situation is essential for the planning and provision of dental services. Early detection of developing malocclusion is important for the implementation of interceptive orthodontic treatment. However, this is not practiced in Gauteng dental clinics due to lack of resources and skilled clinicians. Treatment has been proven to have the potential to prevent malocclusion from progressing into more severe cases that will require more costly specialized orthodontic treatment. Most dental cases at class 1 malocclusion can be managed early by general dentists, while skeletal cases will need intervention by orthodontists. Early interceptive treatment is simple and less expensive than specialized orthodontic treatment and can be made available to a high number of children. That was done to determine the orthodontic treatment need for 8 to 12-year-olds in an early treatment-oriented public health care system. It was found that 94% of the children receiving the orthodontic interceptive treatment in a community, they had completely successful results, and further need for specialized treatment was reduced. Only 2% showed deterioration. Descriptive, cross-sectional, and retrospective epidemiological study was done. Data collected for the study was sourced from the records of the screening of 223 school children that were between the ages of 9 to 11 done at CISO Primary School in 2019. Data obtained was entered into an Excel spreadsheet and analyzed using a SPSS program version 25.5. Results of the prevalence of malocclusion was 63.7%. Angled class 1 malocclusion prevailed at 81%, followed by class 3 at 13.4% and class 2 at 5.6%. The most prevalent malocclusion traits were anterior crowding at 40.8%, followed by excessive overjet at 36.6% and anterior crossbite at 19.1%. There was no significant gender difference in either the overall prevalence of malocclusion or in the occurrence of the different occlusal traits. The high prevalence of malocclusion emphasized the need for early intervention of malocclusion with interceptive orthodontics treatment. Most cases are of class 1 skeletal origin and do not warrant complex management at this early stage. The latter further supports the need for training and resourcing general dentists to employ interceptive measures. Of all the references. Thank you.
Good day, ladies and gentlemen. My topic is prevalence of malocclusions among school children in Western District, Gauteng Province. World Health Organization report that malocclusion has the third highest prevalence among oral pathologies after dental caries and periodontal disease. Malocclusion has a large impact on the affected individual, which leads to discomfort, impaired quality of life, as well as social and functional limitation. Early treatment of malocclusion by general dentists will help to manage most cases. However, clinics are not well equipped to manage such cases, and baseline data is not available to justify this. Early treatment should be initiated because it is reasonably and logic and allows partial or total correction of orthodontic anomaly in growing child and is often brief. It uses simple means, elicits cooperation from patients and parents, and prevents malocclusions worsening. And those treatments include preventative and interceptive orthodontic treatment. Preventative orthodontic treatment include that control, fluoride treatment, caries control in the form of restoration of caries teeth, fissure sealant, plaque control, and oral hygiene education. Interceptive orthodontic treatment is a relatively simple and inexpensive treatment approach that targets developing malocclusion during the mixed dentition stage. Methods used for interceptive orthodontic treatment include serial extractions, correction of developing crossbites, control of abnormal habits, space regaining, extraction of supernumerary teeth, correction of midline diastema, and extraction of retained primary teeth. It also depends on physiological growth, child psychology, and it eliminates compared fixed orthodontic in improving malocclusion in children in their early mixed dentition. Benefit from interceptive orthodontic treatment has been reported from 14% to 49%, and 14.3% of the children could be treated with interceptive alone. In other studies, 94% of children receiving interceptive treatment in a community health clinic have complete successful rates, with only 2% showing deterioration. Orthodontists view interceptive treatment as a useful measure to reduce the severity of malocclusions, ultimately leading to improving patient self-esteem, eliminating disruptive habits, facilitate normal tooth growth, and improving growth patterns. Several studies have suggested that systematically planned interceptive treatment in mixed dentition contributes to a significant reduction in treatment between the ages of 8 and 12 years. Therefore, interceptive orthodontic is found to be effective in improving malocclusion in children in their early mixed dentition. The aim of the study was to determine the prevalence of malocclusion amongst 8 to 11-year-old school children. A descriptive, cross-sectional, and retrospective epidemiological study was carried among 371 school children in a Western District school. A structured form was used by the researcher in 2019 to record information gathered during screening process. The following data, gender, age, type of malocclusion trait, as well as the facial profile was extracted from records collected in 2019. Data was analyzed using the SPSS version 25.5 software program. The prevalence of malocclusion was 38.9%. The most prevalent malocclusion trait was anterior crowding by 18.7%, followed by anterior crossbite 8.4% and increased overjet and deep bite at 4.4% each. Class 1, Class 2, and Class 3 malocclusion were 96.8%, 1.4%, and 1.9% respectively. There was no statistically significant gender difference in malocclusion traits in this study. Male to female ratio was 42% and 36% respectively. In conclusion, the prevalence of malocclusion in the study was low compared to most prior studies. This could be due to an effective school toothbrushing program which is practiced in this area. The high Class 1 prevalence of malocclusion supports the need for early intervention. These are your references, and I thank you.
Good day. The topic I'll be presenting today is the malocclusion profile of school children at Vosloorus Township in South Africa. Malocclusion may not be perceived as a health threat, but it is the third most common oral health problem in the world and hence has serious economic implications. Interceptive orthodontic treatment is not practiced in most government dental clinics. However, it is a cost-effective method of early management of malocclusions which can be applied in a large sector of community. Determining the prevalence of malocclusion will add value in planning dental services in the public sector. In India, Bangalore, Usha et al. Looked at the prevalence of malocclusion of school children between the age of 8 and 12 and recorded the most predominant malocclusion at class 1 at 61.66% and followed by class 2 and class 3 respectively. In China, Zoe et al. Did an epidemiological study and looked at the children with malocclusion in primary dentition. They recorded that 66.3% of their population had one or more malocclusion traits, the most common being the increase over bite and the deep bite at 34.9% and 37.5% respectively. Then they concluded that they had the high prevalence of malocclusion compared to other parts and therefore recommend that early intervention with interceptive orthodontic is important to mitigate the adverse effects of the prevalent malocclusion. Then a study done in Nigeria, Lagos by Utomi in 2003, he looked at the handicapped kids between the age of 7 and 9. 46.2% of these kids needed interceptive orthodontic intervention. The most common malocclusion trait was the anterior crossbite at 17.9%, followed by the tongue thrusting habit, and the lowest was the digital sucking habit. The tongue thrust was the most predominant habit. There was a significant relationship between the open bite and the tongue thrust habit. Then he concluded that the children would benefit from being treated early with interceptive orthodontics. The aims and objectives of the study was to profile the malocclusion of school children between the age 9 and to 11 and to determine the number of school children presenting with malocclusion and the most common malocclusion traits that can be intercepted. This was a retrospective, descriptive, and a cross-sectional study. School children aged between the age 9 and 11 from 3 primary schools in Vosloorus, Gauteng were screened in 2019. The information from the data included the number of children who presented with malocclusion, different malocclusion traits such as overjet, overbite, crossbite, which may be anterior, posterior, or both, and anterior crowding, retained teeth, to name a few. Data was analyzed using SPSS version 25.5 program. 599 school children consisting of 51.6% females and 48.4% males were examined. 55.8% of the population presented with malocclusion. The most common malocclusion was skeletal base class 1, 91.1%, followed by class 3, 6.2%, and class 2 at 2.1%. The most predominant malocclusion trait was anterior crowding at 22.5%, followed by anterior crossbite and posterior crossbite. The prevalence of malocclusion in this study is high and similar to that of other studies. The data supports the fact that general dentists should be upskilled to manage these cases early, and most class 1 problems do not need extensive, complex, and expensive management by orthodontists at this stage. Introduction of interceptive orthodontics in the public sector will aid in reducing the load in the academic institutions by reducing the waiting list, and it will benefit the patients. It will also reduce the development of complex malocclusion if treatment is introduced early. Here is the list of my references. Thank you.
A bit more audible? Is it audible? Excellent. And let's allow Professor Situsa to just give us some commentary around the 6 presentations, oral presentations that we have had. And straight after that, we'll have 3 more presentations that will encompass different topics, of which Professor Situsa will also give us some commentary on. Thank you, Professor.
Patricia, colleagues and fellow researchers, time and time again we are reminded of the basics, and in this instance it's important to have baseline data of any form of problem that we come across so that it can inform policy. So in most of these presentations that we've heard just now, they are based on getting the raw data, which later on will then inform how we manage all these problems. In Nyakale's case, which is a report on what he researched in Free State during his period there, it's important to realize that he discovered that most of the cases fall under class 1. And as mentioned by most of these researchers, dentists would be able to intervene early when given the correct training, as well as the facilities which are needed to achieve this. In terms of the malocclusion trait, when we analyze the malocclusion, the highest malocclusion trait that he found, it's mostly crowding followed by anterior crossbites. And these are the things that we teach dentists to manage. Unfortunately, as mentioned by most of the researchers, this type of interventions are normally not practiced. In Gininda's case, this findings will apply more to clinicians who are doing fixed orthodontic treatment. It's important to understand that when you move a tooth, you've got to move it within an alveolar trough. If the alveolar trough is thin, for whatever reason, you are going to be face a problem where you may fenestrate the tooth, and with subsequent loss of the tooth. It's important now to know that in class 3, as well as long phase treatment cases, we should really be on the lookout for how thick the bone is, and therefore plan our tooth movement accordingly. Thomas looked at, analyzed the supernumerary teeth, and it was a very interesting study. And all of these studies, in fact, are so important that I would advise that they be published. She found that most of the supernumerary studies occur in the maxillary area, and also the premolar, the mandibular premolar area is the one that is heavily affected. I've also fallen into this trap whereby I would go, make a treatment plan, start the treatment, and eventually, when I'm in the final stages of finishing the case, suddenly a tooth appears. And in most cases, it appears in the premolar area. So clinicians, be on the lookout for supernumerary teeth which appear in the premolar area. The last 3 studies, I'm going to sum up, put them together, the study by Makado, Msimang, and Tlalani. The 3 students are actually part of a master's program which we started now recently. And this was prompted by the many tiers of patients as well as parents who come to our facilities and unfortunately do not have access to treatment because there are way too many patients who are coming in and requesting orthodontic treatment. And when you analyze these cases, these are cases which should have been treated early. As we all know, in orthodontics, there are 3 tiers of management. The first would be prevention, and then followed by interception, and then full management. Now, unfortunately, a lot of us wait until the malocclusion is fully manifest and only then come in to request treatment. By this time, it's way too late to implement any preventive and interceptive measures. And as mentioned by most of the researchers, interception is one of the ways in which most of the malocclusion can be reduced. Of interest is that in Tlalani's case, they found that they had a low prevalence of malocclusion compared to the other studies, and this was mostly due to the fact that there are prevention measures which are being taken. There are school programs which are being conducted there to prevent malocclusion. So the challenge is out there to oral hygienists. Implement these preventive measures. They are very important. And if we can reduce the burden of malocclusion in this country, we would be on a much safer footing. The orthodontists will still have a lot of work because there are many class 2s and class 3 cases which need their management. Dentists, try by all means to stay away from class 2 and class 3 management because they are complex in nature. Even the developing ones are difficult, even in the hands of experienced clinicians. And I want to thank you for the presentations and good luck.
Definitely it is very, can you hear me technical? All right. It is a very interesting, I'm really learning a lot. I'm not part of the competition, but one thing I can tell you for sure is that I'm excited to know who the winners in the various categories are, because it seems like all the research, Professor, is really intricate research, and everyone who's competing knows their business. I don't know, are you as judges ready for the work that is cut out for you?
Actually, Patricia, the presentations which we are doing now are not necessarily going to be judged. However, we're looking forward to the publications that are going to emanate from this. So the ones which are going to be judged are those that we did before lunchtime. And the judges are busy finalizing, they are coming to their final decisions regarding them.
So we must look forward to publications on these ones.
Yes.
All right, we've got 3 more presentations that I'd like us to go through. And after those presentations, Professor Situsa is going to come back again and give us commentary.
Hi colleagues, today I'm going to present you my research entitled Types and Frequency of Dental Services Rendered in Gauteng Public Oral Health Facilities from 2017 until 2019. Before I start, I would like to acknowledge my co-authors, Drs. Madiba and Nkambule, as well as the clinical managers from all the public oral health facilities in Gauteng. The primary oral healthcare facilities in South Africa offer a basic dental package. It is essential to monitor these services in order to plan for human resources as well as for infrastructure. Regular audits therefore become essential, especially when identifying overloaded facilities, underperforming facilities, and to be used as motivation to fund additional posts and to employ additional oral health personnel within these public sector services. The aim of the study was to determine the type and frequency of dental services over the 3-month period in 2017, 18 and 19 at all full-time primary oral health care facilities in Gauteng. The objectives were to determine the type and frequency of the services offered, then determine the operator to patient assistant ratio, to determine the operator to extraction to restoration and the extraction to restoration ratios, and lastly to compare the trends in dental services over the 3-year study period. This was a record-based retrospective study, and data was collected from the months of April, May and June in 2017, 18 and 19. All full-time primary oral health care facilities in Gauteng were included, and this amounted to a total of 90 facilities. The data was collected from the attendance registers, and it included the number of patients, the number of operators, and the type and the number of procedures that were performed. The number of dental assistants was also recorded, and the ratio between the number of operators and the dental assistants was calculated. An operator was defined as a dentist or a dental therapist working either full-time or part-time. Full-time was coded as a 1, while part-time was coded as 0.5. Dental assistants were also recorded and categorized in a similar fashion. Oral hygienists were not included in the study. All full-time primary oral healthcare facilities in Gauteng were included. All staff that were employed there, both full-time and part-time, which included dentists, community service dentists, dental therapists, and dental assistants, were also included. Only data from services that were rendered during normal operating hours were analyzed. Exclusions: those facilities which are operating on a part-time basis or satellite facilities, mobile clinics, and prison services were all excluded. Services that were rendered after hours and on Saturdays during overtime were also excluded. Those facilities that were not fully functional for the full 3-year period were also excluded. The data was analyzed using SPSS, and permission was obtained from the clinical managers as well as from the Pretoria Faculty of Health Sciences Ethical Committee. Okay, so moving on to the results, we know that there were 90 primary oral healthcare facilities that were included in the study. We found that May was the busiest month of the entire study period, and there was an increase in the number of patients who were treated between 2017 and 2019. The number of patients increased from 587 to 654. This could be due to an increased population growth in the country, could be due to migration, could also be due to the increase in awareness and knowledge of oral health, and hence an increase in utilization of the services. The slide in front of you shows you the average number of services that were rendered per month by district and by year. As you can see, there's a wide variation in the number of procedures that were performed. The most common procedure, not surprisingly, like examinations and extractions. On average, there were 459 extractions being done per month. There were about 64 restorations being done per month, and almost 44 fissure sealants being rendered per month per facility. This slide speaks to the mean ratios across the 3-year study period. Although the number of operators remained fairly stable over the 3 years, the number of patients increased, and as a result there was a significant increase in the average patient workload per operator. There were no significant differences in the ratios of extractions and restorations with regard to the operators. However, the extraction to restoration ratio increased. It must be borne in mind that the data from overtime and the data from oral hygienists has not been included in this analysis, and this could be an overestimate of the extraction to restoration ratio. So in summary, there was an increase in patient to operator ratio from 376 to 428. On average, 459 extractions, 64 restorations, and 43 fissure sealants were performed per month in all of the districts. Operators performed on average 15 extractions for each restoration, and on a daily basis, operators treated on average 19 patients. Almost all facilities had an operator to dental assistant ratio of 1.3:1. Okay, so in conclusion, there was a significant increase in the number of patients from 2017 to 2019. The workload of the operators was relatively high across most districts as well. The extraction to restoration ratio was much higher than the national goal, but bear in mind the data from overtime and from oral hygienists was not included in the study. The operator to dental assistant ratio was slightly below the national goal of 1.5, and the higher workload among staff should be addressed quite urgently. This would prevent possible patient complications, litigations, and more importantly, stress and burnout amongst the staff. Thank you.
Good day, my name is Nazin Lelo and I'll be presenting on behalf of my department, and the topic of my presentation is COVID-19 and its impact in the dental setting, a scoping review. Virus disease COVID-19, which started as an epidemic in Wuhan, China, was subsequently declared a pandemic by the World Health Organization. It has affected many lives, people from different socioeconomic backgrounds, cultures, and professional backgrounds. Dental professionals are particularly at risk due to the nature of their clinical work. Therefore, protocols, which encompasses the clinical workspace as well as the principles guiding their practices, must be well formulated and strictly followed to protect themselves, dental staff, and the patients they serve. The focus of the scoping review is therefore to recognize how the nature of dental work may contribute to the spread of COVID-19 and how this may be circumvented whilst remaining committed to set clinical, ethical guidelines. The study looked at coronavirus in the dental setting, which included the clinics, waiting rooms, and the working area, ethical principles, types of transmission, and types of infection controls. This image shows the typical routes of transmission, which is either via direct transfer, such as coughing, sneezing, or droplet inhalation, or via contact transfers. The purpose of the study was to identify any primary research that has already been completed, as well as to recognize how the nature of dental work may contribute to the spread of COVID-19 and how this may be circumvented whilst remaining committed to set ethical guidelines. The aim of the study is to conduct a scoping review to identify the research that focuses on infection control measures and transmission of SARS-CoV-2 or COVID-19 infections within a framework of accepted ethical principles. The objectives of the study are to evaluate the literature focusing in ethics as it relates to the dental profession during the COVID-19 period, to gauge the literature regarding infection control and disinfection measures and transmission of COVID-19 during the pandemic, and lastly, to identify evidence that may serve to guide practitioners regarding these infection control measures and transmission of COVID-19 in a dental setting. Methodology. The group of researchers looked at evidence on COVID-19 related to the dental profession, with a special focus on infection control, transmission of infections, the ethical principles related to these, and the challenges it presents with in the dental clinical setting. The design of the scoping review framework is based on the Johanna Briggs Institute framework of evidence synthesis, which consists of 5 stages. The stages include identifying the research question, identifying relevant studies, study selection, presenting the data, and collecting the results. As a department, we followed these stages to complete the scoping review. The literature was limited to the English language and included evidence from different health settings. Different study designs were not limited to primary research and therefore included opinions, reviews, guidelines, and recommendations from oral health groups and organizations within the last 5 years. Research related to the other areas of dentistry not covered by this scoping review was excluded. Databases and scientific working group websites used were PubMed, ScienceDirect, Scopus, Elsevier, and Wiley, and including the following health groups: WHO, FDI, ADA, CDC, SADA, and HPCSA. Planning of the study. The prosthetic department divided into pairs to complete the searches. The research excluded any duplicates as per the 3-step plan. 1. Articles were initially screened according to titles. 2. Abstracts of the selected titles reviewed. 3. Data extraction was completed from the full text of included articles which was obtained. The different steps for the scoping review were all completed as per the inclusion and exclusion criteria. Data extraction from the full text version of the selected studies was finalized between the reviewers and consensus of data reached through discussion. For analysis of the data, the search for articles as reported using a preferred Prisma flowchart. For all included studies, characteristics were analyzed descriptively and followed the data extraction criteria, which needed to be modified slightly depending on the type of report. Example, when published, location, and study design. A basic appraisal of these included studies or articles were completed. The data was then reported narratively using the criteria set for the objectives of the study. Results. The results were completed using the Prism flow diagram. A total of 402 articles were retrieved, of which 102 were duplicates, and 231 were unrelated to the objectives of the current scoping review. After reading the abstracts, the full text of 69 studies was assessed for eligibility, of which 26 were finalized for inclusion following the objectives and inclusion criteria. It is important to note that data extracted were not from primary studies, as no SARS-CoV-2 or COVID-19 related research was completed in the dental setting. No papers focused on primary research or interventions or control studies. The information retrieved were largely from country-specific oral health groups, health policymakers, and dental organizations to provide guidance to dental practitioners during such an unprecedented pandemic. Infection control within the dental setting. Apart from one cross-sectional survey, the remaining articles included reports, recommendations, or reviews, including a systematic review or guidelines evaluating another infection outbreak. As previously mentioned, no papers focused on primary research or interventions. Although the nature of the research obtained was of inferior quality, it could serve as a guide for practitioners and dental hospitals. Transmission within the dental setting. The seminar instructor transmission reviews principally discussed several measures on how to protect staff and patients from becoming infected. Other discussions included spread via social interaction and includes where the virus attaches, how it attaches on the different surfaces in the clinics, types of actions resulting in this, such as sneezing, coughing, and talking, and how dental practices need extra precautionary measures to prevent the spread. Some recommendations included pre-procedural mouth rinses, use of a rubber dam, and limited handling of dental work, etc. Discipline-specific recommendations included disinfection protocols for dentures, wax liquid blocks, and impressions in prosthetic dentistry, which was of particular interest to the researchers. Ethical principles relating to dentists. Based on the 5 ethical principles, the review assessed us on how we needed to make the change and move from the set normal principles and shift the focus on saving lives. It became the practitioner's duty to now inform patients that they were at risk of becoming infected. The principles of patient confidentiality was also compromised, as patients needed to be questioned about their COVID status. Health and welfare of frontline workers, their rights and responsibilities should never be compromised while treating patients. This is of utmost importance. To conclude, no quality evidence is available that can support the positions recommended or stated to prohibit transmission of infections, but these may be used to mitigate patients becoming infected. These are mere guidelines that may be used in the event of a pandemic. A different ethical framework is required during a pandemic, which must be informed by evidence.
Good day everyone, and thank you for the opportunity to present my work, which is titled Validation of the Modified Oral Health Impact Profile among Adolescents in Johannesburg. This study is phase 3 of a bigger study which has been conducted as part of my PhD. Oral health related quality of life. It is the effect of oral conditions overall the functioning and the well-being of individuals, including adolescents. It influences how adolescents grow, how they look, how they taste food, how they live their normal life, how they socialize, and how they perceive their social well-being. We can all agree that these activities are essential elements in the formative years of adolescence. Now, oral health related quality of life is a concept that is socially and contextually sensitive. So therefore, tools that measure oral health related quality of life should be contextually and socially sensitive in order for us to accurately measure the oral health related quality of life in our South African setting. The adolescent is a phase. It has been shown to have countless life challenges and changes generally, besides just living with the HIV infection for those adolescents living with HIV. They have been termed an emerging population because they have been born with HIV, they are living through adolescence, some even up to adult and parenthood, and thus they are a major focus of public health and indeed dental public health due to the oral disease burden. The risk factors generally for oral disease and specifically for oral health related quality of life have been shown in literature to be related to the socio-demographic factors, clinical and behavioral factors, poor access to dental care, and poor access to preventive dental offices that have fluoride, for instance, poor diet because they are adolescents. Adolescents also have issues with regards to independent to seek care, compliance generally. They are prone to experimentation and lifestyle issues, and they have been shown to have a low priority for oral health. Now, this may or may not be the case in South Africa, considering that quality of life it varies with the socio-cultural and economic influences. In the African settings, the adolescents generally, and also specifically those that live with HIV, have been marginally investigated in the broad field of oral health related quality of life. Now, adolescent subjective inputs are important and necessary, and they should therefore be included in our general treatment protocols. Now, Mosky and colleagues in their US-based study They recommend that a risk-based regular monitoring is important for those living with HIV in order for us to identify their special needs. Publications and published studies in this field of oral health-related quality of life is sparse and rare in the African locality, and we have none that exists in our South African setting. Therefore, the aim of the study was to perform the validity of the modified COHIP tool among the adolescents in Johannesburg, and also to establish the determinants of the oral health-related quality of life among these same adolescents in Johannesburg. The study was a comparative cross-sectional study design where the study population were two groups of adolescents, those that were in school and those that were in the HIV Wellness Center, recruited from the Community Oral Health Outreach Project of the Department of Community Dentistry and Vets. Now, how the adolescents were included into the study, we used a certain exclusion-inclusion criteria. For the school participants, they were excluded if they reported a medical history. They were excluded if they reported to be on chronic medication, and they were also excluded when they did not have a relevant consent in assent forms. For those that were in HIV, they were included in the study when they were recruited as they were going to get their routine care. They were also included if they provide the necessary assent and consent. Sampling procedures were such that the sample size was calculated for both the school group and the HIV wellness group. For the school group, using the sample frame of 400 learners, assuming the 5% error and the 95% confidence interval, an estimated number of 240 sample size was calculated. However, 280 learners were invited to account for the missing values and information. Similarly, in the HIV clinic, the calculated sample size was 210. However, more were recruited to account for the missing information and values, and those that would refuse to participate. For the school group, the learners were selected randomly using the class list as a sampling frame and using the computer-generated numbers from the class list. They were selected up until the required number was reached. And for those in the HIV clinic, they were examined and recruited as they came for their routine care up until the sample size was reached. The study received ethical approval from the Human Ethics Committee at the University of Wits. How we collected data, we used three forms. Firstly, the questionnaire, the clinical examination, and the review of the medical records. Now, I said this is the third phase of the study. The second phase of the study included a qualitative exploration study where we were looking qualitatively at the views of on the perceptions and the understanding of the adolescents when it comes to oral health, oral diseases, and how it affects their daily activities. The thematic content analysis from that study yielded three broad main domains: individual level, external level factors, and social impact factors. Now, these factors were considered important and contextually relevant for this group, and therefore they should be included in the questionnaire. In addition, clinical examination was done to screen for dental caries. We used the DMFT index, and for those that were in the HIV clinic, we look at the medical records to check the HIV clinical markers such as the viral load and the CD4 count. In addition, to do a clinical examination of the oral lesions, we used the case definitions for HIV/AIDS Research Alliance group. The examiners were calibrated, and the intra and inter-examiner kappa score was found to be acceptable at 0.8. This is an example of the modified 29 item 2. The questions on my left are those that were found in the original tool. For instance, number 1, have you had pain in your teeth or have you had toothache and in the past 3 months? So the adolescents had to respond from never, almost never, sometimes, fairly often, up to all the time. Same applies to the other items in the original tool. For instance, have you had bleeding gums in the past 3 months? Again, they needed to give the same response. Now the items on the right, these are the new items that arose from the new themes. The new themes were dental access, the experience with regards to their dental care, and also how they're coping with their oral conditions. For instance, number 22, have you had a problem with getting dental care because my family cannot afford? So again, they needed to choose one of the 5 responses from the 5 Likert scale. With regards to their experience to care, number 25, for instance, at the dental clinic, they don't address my teeth and mouth problems when I complain. Instead, they focus on other issues. And then lastly, on the theme of coping, for instance, number 27, if I have a problem with my teeth or mouth, I do not tell anybody. Again, they needed to respond, choose one of the 5. How analysis was done was all the items were captured from the questionnaire into Microsoft Excel and then exported into data for further analysis. Descriptive statistics was done where socio-demographics were calculated in terms of frequencies and percentages. We also calculated the DMFT scores, dental experience scores, and also the quality of life scores. Further analysis was done to compare the 2 groups by research site. We did bivariate analysis by dichotomizing D0, which means there is no decay, D greater than 0, which means there is at least 1 decay, and same applies to the DMFT, just to compare the results by either the research group and by dental caries prevalence, toothache, and their general self-rating. To calculate for the scores, we just summed all the responses, and the score ranged from 1 to 45, with the higher scores implying a poorer or a health-related quality of life. We also subjected the questionnaire to the Cronbach alpha test. And then lastly, exploratory factor analysis was done on the tool to determine how many subscales or dimension would be yielded by this 29 item. We also looked at the validity of the questionnaire. For conversion and discriminant validity assessment, the following hypothesis was assumed. The higher the score of the cohort should relate with the poor oral health self-rating. It should also be related to whether they reported pain, whether they have toothache. It should also be related to the fact that there is active dental caries from the DMFT index dental examination. Exploratory factor analysis explains 76% of the total variance based on the 5 items from the original cohort 2. From now on, I will report on the results. Just on the first part with regard to the demographics, the total sample size was 504 adolescents, and the overall DK score was about 1.6, which means at least one adolescent had about 1.6 teeth or nearly 2 teeth that were decayed. The overall caries prevalence was considered to be high at 62%. Now, when comparing the results by site, both groups had the same mean age. Looking at the unemployment figure, you'll see that those that were in the wellness side had more parents that reported to be unemployed compared to those in the school side. Looking at the dental caries prevalence, it was higher in the school side than in those that were in the wellness clinics. The oral lesion prevalence for those in the HIV clinics only, obviously for obvious reasons, it is just 22%. The mean score for the D was lower in the school side. However, the treatment component was higher in the wellness side, the missing component and the felt component. Looking at the mean score, again comparing by research side, underneath there in red, you could see that those that were in the school side, they had a higher quality of life score, which meant poorer quality of life compared to those that were in the HIV side. The overall modified score was different, statistical difference between the two groups. The Cronbach alpha was found to be acceptable at 0.84. Anything that is between 0.75 up to 0.95, it is considered excellent. And the scores were higher for those that were not in care, that is those that were in schools. The scores were also higher for those that reported toothache. They were also higher for those that were found to have active decay. They were also higher for those that self-reported that they have a poor oral health. We also did regression analysis where we found that after adjusting for confounders, those that have dental caries and those that were in school were more likely to have poorer oral health related quality of life or higher COHAPE scores. So in conclusion, the results show that the tool was valid for the site for these adolescents in Johannesburg. It had good psychometric properties. It is advisable that before a measurement tool is used for the first time in a setting, it should be validated and tested for applicability to that contents. As a result, we found that it was relevant and applicable to these adolescents in the sites in Johannesburg because the higher scores were related to the higher antrogen caries. They were also related to toothache and to poor oral health self-rating. However, more studies are recommended and suggested to retest the new tool with this new context-relevant subscale in the setting to further validate the tool. Thank you very much for your attention.
I'd like to hand over to Professor Situsa, who'd then take us through the summary of the last 6 presentations that we had. Remember that we do have the WhatsApp number. Please do utilize it. We'd like to hear if you've got questions. We'd like to hear if you've got comments. Don't be silent. WhatsApp us. We want to hear from you. It is the 50th virtual conference for the IADR. So that means let's celebrate the centenary year with a big bang. All of us are welcome to comment. The WhatsApp number is 064 656 0131. Over to you, Professor.
Thank you, Patricia. Colleagues, once again, we've had 3 very interesting presentations here. And I remember very well a few years ago when I joined the dental fraternity, one of my colleagues told me that, well, why do you join that field? Why do you decide to study that field? And his reason was that work is underway to wipe out all dental problems. Well, here's a study by Bayat which shows that there is a significant increase in the number of patients over the years who are visiting all the clinics in the Gauteng region. And the number one reason why, or the first number one treatment which is offered is extractions. And we all know what happens after teeth have been extracted. It means more and more work for dentistry. So research of this nature is important, not only just to highlight the number of cases which are there, but however, to show to clinic managers as well as managers in the health fraternity to show them that it's important to put more resources into dentistry. And it also shows us that it's important for us to focus more on preventive as well as where applicable interceptive measures rather than waiting for the ultimate treatment. Another study by Lelu, this study actually focused on COVID-19 research, and as we all know, this is new, and hence the findings of this study. There's very little data in terms of what affects our clinical day-to-day management of cases. So we're looking forward to more studies which are going to come out very soon. I'm sure in the next year's presentation, we'll have a lot more information on this. And then the last study, and I remember very well, a question was asked to one of the panelists to say, what did you do? Did you validate your tool which you used? And honestly, I think the study by Malele and Kolisa is very important to all of us, so that if you take a study which has been used elsewhere, the question is, will it apply in your situation? And very often we take tools which were used elsewhere and we apply them to our sample population and we draw conclusions from that. But the question is, did we really measure what we were supposed to measure? And I think, in that regard, as researchers, we really need to focus on studies of first validating our tools before we apply them. I thank you.
Thank you very much, Professor Situsa. Now we've got another 5 presentations, oral presentations that we are going to view. And straight after that, we are going to have Professor Mupulai, who's going to give us commentary around those.
I'm Dr. Jan Mulder from the University of the Western Cape, and today we will be looking at the physical properties of nanodiamond modified glass ionomer restorative cements. It was to assess the effect of the modifications when we add the nanodiamonds to the GICs. Now, the rationale for the study was that the functional groups that we obtained from the nanodiamonds would induce some interesting interactions with those of the glass ionomer setting reaction. One of the most important physical properties is proportional limit, because that is the point where the material can still rebound back to its original state without any damage. Once we pass that point, the material will fracture. In our methodology, we see that 9 GICs were used, and this consisted of Fuji 9 from GC, Keytech Universal from 3M SPay, and Riva Self-Cure from SDI. Now, they were modified with either a 5% or a 10% nanodiamond powder. And then Group A assessed the compressive strength and proportional limit, and Group B the surface microhardness. We see the typical diagonals of the surface microhardness, in other words, Vickers hardness, and on the right, a typical sample after the compression test has been performed. Analysis was done with one-way ANOVA tests, and then also the t-test was used in order to analyze the variances of the means. For our compressive strength and our proportional limit, we had to first stabilize the transformation of the data, and we did that by using the logarithms. This graphical representation, we see that our materials from the commercial side, which is Fuji 9, Keytech Universal and Riva Self-Cure, are represented in the blue columns. And we can see that for proportional limit, our GC product performed better than Keytech Universal and Riva Self-Cure, even though those analyses were not significant. If we look at our nanodiamond modifications, we will see that the items in bold illustrate the significant difference with that of the commercial material. And the general trend was varying between the 5% and the 10% modifications, of which performed the best. If we look at the proportional limit, for example, we can see that the 10% nanodiamond modification did give a lower proportional limit for that material, but it was not significant. Compare that to Keytech Universal, we see that the 10% decreased it significantly. compared to Riva self-cure, there was no significant difference. And all of this comes down to the chemistry. Strength. We see that the nanodiamonds absorb the aluminium and the silicon particles. Therefore, there are less of these particles that's able to take place during the maturation. Sodium is not absorbed by the nanodiamonds to the same extent as the aluminium, silicon, and strontium. Therefore, there's more sodium available, and this sodium occupies the carboxylic groups during the maturation of the material, and this creates havoc because now the aluminium, silicon, and strontium is not able to bind to the carboxylic group. Therefore, the physical properties are also decreased. But the nanodiamonds form these agglomerated particles, and there's varying crack formation through them, and that's why, especially with the surface roughness, with the surface micro hardness, we could see a decrease in the strength. Look at these particles, we can see how they've agglomerated, and these bigger particles do not integrate well into the powder, but we can see the gray halo from the smaller nanodiamond particles in their loose form and how well they've integrated with the powder, and that is ideally what we would like to have. If we were to look at a sample after compressive strength, you can see these bigger particles and how they've actually decreased the strength. This is because of this crack formation that propagates through these large particles, and that's why we need to ensure that these large particles are not included in our glass ionomer powder when this is going to be mixed, because it will decrease the physical properties. When these larger particles are removed, the physical properties are actually on par with our commercial material. So it does not improve it significantly, but it is on par. The conclusion from the study was that in order for us to achieve 100 MPa, only the 3 commercial materials achieve that, with Fuji 9 10% and Keytech Universal 5% nanodiamonds also achieving that. Generally, the surface microhardness was reduced, even though not always significantly, but that was due to those large agglomerated particles that was creating havoc on the Vickers hardness testing machine. So in order for future research to be successful, we need to ensure that we retain the nanoparticle component and that we ensure that only the nanoparticles are incorporated into the powder, and we do not have these large agglomerated particles that form during the very, very string forces between the van der Waals forces that causes this. I request your questions. Thank you.
Good day, my name is Corné Postma and I'm going to present the digital access divide at the South African Dental School. We have no conflict of interest to declare.
Good day, I am Ronald Mott.
Access to information is a challenge for under-resourced students. We know that because we work in this space, and this relates to the devices and the internet connections the students have access to, and it also relates to the inequality.
Good day, I am Ronald Mott. My topic for today's presentation is dental educators' views and knowledge of competencies required within a competency framework. Societal and delivery changes, improvements in oral health, advances in science and technology, together with the complexity of today's evolving environment, provide some guiding principles for dental education in the 21st century. Various core competency frameworks inform dental curricula for dental schools globally, and in South Africa, AfriMed's competency framework guides the dental curricula and accreditation for all the dental schools in the country. Why dental educators' views are important. Dental educators are responsible for teaching undergraduates, are expected to contribute to this accreditation process with the guidance of dental deans, committees, etc. Considering that dental educators are involved in the teaching and assessment of undergraduate dental students, their views on the required competencies for dental graduates would therefore be valuable. The aim of this study is to explore and describe the dental educator's views and knowledge of core competencies required within the AfriMed's competency framework. Methodology. Case study design was used. It was a qualitative research study. There were 2 focus groups of dental educators at UWC. That was used for data collection tool. Population, purposefully sampling was done. Inclusion was clinical discipline module coordinators. The interview guides were used for the interviews. The interviews were recorded, then transcribed. Atlas TI was used to assist with coding, and thematic analysis was conducted. The first question, in your view, what are the competencies that the dental graduates require upon graduation or completion of their dental degree? Major themes from the responses to the first questions were clinical competence, professionalism, communication, private practice, and ethics. I will now highlight some of the quotes as it relates to the themes. For clinical competencies, some of the answers were able to gather clinical data and to use that data to render a diagnosis, and from that diagnosis to be able to develop a treatment plan, and so that is a competency that we strive for. For professionalism, the quote, professionalism hand in hand with communication with your skill. So professionalism should be a competence. Quotes related to communications. Communication and professionalism are 2 that fall under soft skills competency required. Quotes under private practice were private practice and the business skill, entrepreneurial desire and skills to step up on their own. Ethics quotes, I think the ethics is also important, as this should be included with competence, and it may be an attribute, but it is also a competency. Emerging competencies were digital competencies that was highlighted, internationalization, and evidence-based dentistry. And these are some of the quotes related to these competencies. Although the importance of AfriMed's core competencies was recognized, concerns regarding factors affecting its successful implementations were raised. Issues regarding the teaching, the assessment, and implementation of the core competencies were highlighted. Evidence-based dentistry, internationalization, and digital competencies were highlighted by the dental educators as essential for the 21st century dental graduate. These competencies are not explicitly included in the AfriMed's core competencies framework. However, these competencies would ensure that they, the dental students, are prepared for the changing world of work. A review of required competencies for dental graduates should be considered in line with general and dental-specific global and societal changes. This would ensure that dental graduates stay relevant and prepared to practice dentistry in the 21st century. Thank you.
Good day, my name is Corné Postma and I'm going to present the digital access divide at the South African Dental School. We have no conflict of interest to declare. Access to information is a challenge for under-resourced students. We know that because we work in this space, and this relates to the devices and the internet connections the students have access to, and it also relates to the inequality that's prevalent in South African society. So we decided to investigate this divide in the dental school context using a cross-sectional custom design survey in 2017. We targeted all second to final year dental students, around about 240 of them. The questionnaire included the demographic part, including where the students resided, the devices they used, their connections in terms of quality and cost. We also asked the students whether they were feeling disadvantaged in comparison to their peers. We also asked questions about printing costs, and we allowed the students to respond to open-ended questions about internet speed and critical access to the internet. So we had a very good response rate of 87.2%. Very high percentage of students who had access to devices like laptops and smartphones. 158, that's about 72.5%, had internet infrastructure at home, but 27 indicated that they have problematic access to the internet at home. In terms of feeling disadvantaged, about 15% of students indicated that they felt that they were lagging behind their peers and it was not fair. About 25 also indicated that they lacked appropriate devices for study purposes. In terms of cost, personal infrastructure, the monthly cost was around about 434 Rand per month. Data contracts at that stage for the students who reported on this was about 362 Rand per month. Pay-as-you-go data costed them close to 400 Rand a month. And then there were those who were using the Tswani Wi-Fi network. There were 35 of them, of which 16 didn't feel safe in the spaces they used the network. They rated the reliability of this network only as 5.45 out of 10. Many students used the UP network, also free data, and that was 7 out of 10, the rating of the reliability. Then in terms of access to computer facilities, 28 students used the UP computers weekly or more frequently, 97 occasionally, and 70 reported that they normally had to wait a turn to get a chance to work on the computer. And at home even there were 24 that indicated that they had to wait a turn to use the computer. In terms of internet access when they needed it the most,
Good morning. This is Leanne Sykes and I'm going to present our research on dental students' self-perceived competency using the internet for learning. There's been a strategic drive towards teaching more online learning and getting lecturers to post information on the internet so that the students can come to the class already having read something beforehand and then engage with the lecturers during the lecture time and not waste the time having formal lectures as in the past, and then go home and consolidate their knowledge with after-class revisions or assignments posted by the lecturers. This will take less emphasis off the year marks as the grounding mark. For the lecturers, there will be less handout notes. They can upload material and references as they like and as they need to modify them with current information and explanations. They can add illustrations, procedures, materials, technique, post assignments or revision exercises, give feedback, monitor progress, display the grades, and also the nice thing is they can communicate on a personal level or via group messages very fast and very quickly with the students. The students can access the material before the lectures and be prepared when they come to class, which won't waste time during the lectures. They can also study at their own pace, go back to topics if they want to, and the aim is that we're also going to teach them how to add to the postings that the lecturers have given there, to try and develop a bit of critical thinking, critical appraisal, and problem solving. But this can only be successful if they know how to navigate the facilities and the functions, extract relevant data, and organize this accurately. So the uptake and the usage of this has been particularly slow until the coronavirus came along, when we had the shutdown and there were no lectures and no clinical sessions, and it's forced lecturers and students to start using the internet. But when we did this, we just presumed that all the students had access and possessed the technology and were comfortable using the internet, but it had never actually been formally investigated. So this research was actually done before the COVID lockdown, but obviously the findings are much more significant now. So we wanted to look at the students' competencies and see what they preferred to use when they were teaching and learning on the internet. We wanted to see what their levels of competence were and to establish any problems that they might have with the internet usage so that we could implement the necessary changes if we wanted to. The study took the form of an anonymous self-structured questionnaire. There were also some open-ended questions that were given to all the students from the 2nd to the 5th year of study. From the results, we saw that we got a very high percentage, 87% answering, and the answers were spread evenly between the 2nd to the 5th year of study. It's also interesting to note that at least 1/3 of the students live in rented flats or the university residences, with very few living at home or in communes or elsewhere. But we did discover that pretty much the whole class, 96%, own laptops or computers or smartphones, so they are able to access the internet frequently. When we looked at our responses, we found that there was a very high competency level in the 90s for using search engines like Google, Yahoo, for downloading photos, for interacting with friends, for accessing printed information on the internet. But when we came down to the self-directed learning, looking for the latest information, reading scientific papers, or carrying out their own assignments and research, the levels were very low. They were 70 to 69, so students are not that competent for these functions. We also looked at how often they went into the internet, and we saw it was often, weekly or daily, for getting lecture materials, study guides, looking for their marks, and checking for things on ClickUp, reading announcements. It was also very, very common. But as far as doing quizzes and submitting other assignments or doing independent reading and research, it was actually very low, maybe once or twice a semester. Some of the students said even never when it came to doing certain assignments. And the usage of the computers and the computer facilities was also very, very low, which we were quite surprised about. So we found that looking at these results, in theory, the move to the flipped learning and the blended learning seems to be justified, and it's well within the students' capabilities, as most of them are competent using the internet, but they're not competent using it for doing things like quizzes, assignments, and self-directed learning. And we're also a little bit worried because these are the critical skills that we really want to teach them. And it was interesting that in the open-ended questions, over 90% of the students still said they prefer to get printed material and don't like using the internet. We also found that a lot of the staff don't seem to be using the internet to their full capacity, and I think it's because many of them haven't been trained and are still of the old school and are still trying to rely on lectures, which is not what we want. So in order for us to do flipped learning, we actually have to train our academics first and then the students second. And we really, really need to find lecturers. A lot of them are still saying, but we've always done it like this in the past, so why should we change? And we need to have that paradigm shift changed among our own educators and the lecturers before the students will buy into the flipped learning. So in conclusion, I think we have to start to say we need to be the change that we want to see in our students. Thank you for your time.
Thank you very much. And let's hand over to Professor Smu Iadr so that she can give us some commentary on those presentations.
Thank you, Ms. Ntuli. And I would like to say thank you to the presenters who have taken us to another paradigm in our conference today. Previously, we've been focusing mainly on quantitative research methodologies, but the last 4 presentations have really been looking at qualitative and looking deeper into the issues that face education and how we learn. Starting with the first presentation on the physical properties of nano-diamond modified glass ionomer restorative cements. What this really emphasizes is the reason we are at the schools that we are at tertiary level, where we need to constantly improve on the materials that we use in order to provide our patients with improved restorative materials. And that study really highlights that, because it's looking at improving commonly available materials to make them stronger and therefore more durable and more effective for clinical practice. The last 4 presentations focused on education and how we need to be learning facilitators, what Dr. Moefi told us this morning, and the essence of being lifelong learners as well. And the last 2 presentations, despite the fact that the studies were done before the pandemic, they highlight the issues that really came to the fore during the pandemic. And they demonstrate the need for institutions to change the way we teach and therefore change the way we learn as well. And especially with the last presentation, where the emphasis was on both the students and the teachers to change their mindsets and get on with doing things differently in order to teach and learn effectively, and not assume that we know what we're doing, or because we've been doing it for a long time, that's the right way.
Thank you very much, Professor Iadr. I think this part of the program has been concluded. However, we've got a very special guest, someone who has graced us with her presence, and I think when she entered the conference center, everyone who's present, obviously it's just a handful of us due to COVID-19, was just in awe that, wow, we've just been graced with the presence of Professor Eunice Siko, who's the Deputy Vice Chancellor for Teaching, Learning and Community Engagement at the university, Sefako Makgatho Health Science University. Since she started at the university, she has impacted such a lot of change and touched a lot of students' lives in terms of the programs that she has been engaging with. We are really graced to have her presence, and we really do appreciate her. Welcome, Professor. Please give us an address.
Thank you. I think I'm free to take off my mic. my mask. Thank you very much, Program Director, for this opportunity of being part of this conference. I'm honored, really, to be part of the 50th Scientific Online Meeting of the International Association for Dental Research, which is hosted by Sarcoma Health Sciences University. I'm saying it with pride, let me put it that way. You know, when I received an invitation and they were saying to me it's going to be live and face-to-face, I thought, I don't know what these people are talking about, and I'm not sure if they're going to achieve it, but here we are and today, and it's really happening, and I really appreciate what I see today. This is a place where ideas, knowledge generated through research is shared by experts in dentistry, medicine, science, and technology. My wish is that it should not be knowledge that is shared here today and we end here. After this conference, your ideas are expected to be translated to publications in order to increase the research output, development of new academic programs, the need for knowledge to be translated to our communities where science becomes relevant. This should also lead to improving clinical teaching, because in health sciences, clinical component is quite core and is important. And it should also lead to improvement in delivering teaching and learning, innovation on how we teach our students, which is, I think, within 2 minutes that I sat here, I heard that, especially because of the environment, the new normal that we are experiencing in 2020, that we have to be creative, we have to be innovative, and making sure that we integrate technology in order to teach and to communicate as we are. And we also to produce and create and make sure that our graduates are employable. You know, we cannot, with a high employment rate in the globe, around the world, we need to produce graduates who are employable and graduates who can go there and change their lives and improve the economy of the country. So our country is currently going through a time of a pandemic, at the same time re-engineering primary health care, introducing the national health insurance. And while we are doing that, the country needs us. It needs graduates. We are expected to produce graduates who can be able to go out there and deliver what is needed in South Africa. The integration of technology in order to be relevant to the fourth industrial revolution cannot be overemphasized. That I hope as you are deliberating today, that cannot be left behind, because we need to prepare our students for them to be able to be part of it. As institutions, even institutions in practice where students are working, including our national digital strategy. So as we prepare our students, they should be able to get there and hit the ground running. We need to increase the numbers of our qualified graduates, and you know that we all in health sciences working towards supporting the national strategy for human resources. So we need to make sure that our graduates succeed, and as they succeed, they should be competent to be able to function. And we should give the department and the world graduates who are critical thinkers, problem solvers, team workers, who are patient-centered. I want to emphasize patient-centered, who are enterprising, and who can provide leadership in an ethical manner. This is what we need in South Africa, and I hope that today and tomorrow, as you are deliberating solutions on how to achieve this, and you are exchanging your ideas, will come out, and I wish you well. Thank you.
Very much, Professor Eunice Siko. It was a great pleasure to just have you and your presence here, and I'm sure that we are all inspired afresh, and we will definitely make sure that we do, as you say, that we continue in our engagements. It is time now for us to give you a token of appreciation. We are really glad that you are here.
Thank you, Prof, for your presence. Thank you for gracing this occasion. Thank you. Thank you. Oh, thank you. Wow. Thank you so much. Thank you. Oh. Okay, thank you so much.
All right, that brings us to a time where we can all take a 10-minute comfort break. We'll be back after 10 minutes, and I know all those who are part of the competition are eager to know who the winner is. I know the judges have been deliberating, scratching their heads. There's been some telling of numbers. There are auditors who were busy in the background just checking the point systems, and I was also making sure that no one is choosing favorites. If I had it my way, I think when we come back, I'd say you are all winners from those who were part of the competition. However, it's not Patricia's show, is it? So what we are going to do is take a 10-minute break, and when we are back, we will continue with the program. We are back again after our short and brief break, and we are back at the most exciting part of today, at least for me, because winners are going to be announced. And you are aware that we have been sending you through to the website www.smu.ac.za/IADR and /2020. That's me. It's the end of the day. Please do forgive me for the fumbling. But yeah, it's life and it happens because we are live. I hear that there's a lot of you viewing via Facebook, via Instagram and YouTube and the likes, and that's very exciting because it's time for you to tell your friends and your families to come closer as we are about to hear the winners. Before we do that, we are going to allow Professor Motloba to give us more information around the poster competition. What posters were there? How many submissions were made? What was the criteria for winning before we even get to announcing the winners?
Thank you very much, Pat. It's actually very exciting, you know, to talk about the poster presentations. Having listened to, you know, the oral presentations that were very variable, you know, attending to all the aspects of oral health. We had a lot of showing in terms of poster presentations, spanning from oral pathology, prosthodontics, maxillofacial oral surgery, community dentistry, restorative dentistry, and orthodontics. And I would like to, on behalf of the local organizing committee and the IADR, to thank all the participants, you know, for the hard work. The posters are available on the website for viewing, and that should continue probably even beyond the conference. I think that is something that probably the local organizing committee will have to then talk about. But in the meantime, as we've indicated, please let your family members, friends, you know, go through the website, you know, and actually understand the amount of work that we've put in and acknowledgement that you'll get from all of us as colleagues. We had about 8 poster presentations for oral pathology. For prosthodontics, we had about 5. Maxillofacial and oral surgery, 6. Community dentistry, we had 3. Restorative dentistry, 6. And orthodontics, we had 1. It's not just a poor showing that our chair, for the better part of the day, Professor Situsa, had 1. I think most of them were in the oral presentation. And I think on behalf of the organizing committee, let me thank you once again and hand you over, you know, to the chair to announce what I think we've been waiting for. Over to you, Professor Bayat.
Before we do that, Professor Motloba, we need to go to an ad. One of our main sponsors is Colgate, and they'd like to just show us a bit of a video. And I think from everyone, we are aware that that's one of the biggest brands when it comes to oral hygiene. Am I correct? I've put it right?
Yeah.
So let's honor them and give them this opportunity. And soon after that, we will be coming back with the results. I don't know. Are you excited about the results? Are you, Professor Bayat? There's something that I heard before the lunch break that Professor Madiba has a twin brother. And now when I was looking around, you know, I told you I was doing my investigations around, you know, I was auditing, right? Visual auditing around, are the winners going to be the correct winners? And I was worried when I saw Professor Madiba. I was asking myself, is this his twin brother or is the same? Was it you or your twin brother, Prof?
Not at all.
Who was it? Because I saw someone that looks like you.
It's me.
Okay, in living color. In living color.
Living color, thank you.
And how difficult was the process, though?
It was quite challenging. Remember, for the postgraduate, we had 4 and very good presentations, and all of them of high quality. Unfortunately or fortunately, we always have 1 winner, and that is the challenge.
For us, for the undergrads, we only had 1. So it wasn't a matter of competition, it was just a matter of seeing the quality and making sure that they meet the criteria.
So quality and criteria. Professor Motloba, what do you think for next year? should there be another competition, what should professionals be looking out for? What are the key pointers that you should look out for when you enter a competition of this nature?
Well, I think there were a couple of things that were mentioned, towards the end by respective, chairs, that one, the quality will depend on the methodologies. Dr. Malele, for example, talked about validation of the tools that we need to use. I think that's very important. Secondly, you also need to be topical. We chose 4IR, and I think the speakers were very clear and eloquent that we are not going to go back. So the topics need to be, up to scratch and current. You've spoken about nanotechnology, that guys are using. So I'm not suggesting that your qualitative studies are not important. They actually contribute, but I think we need to start to then research, on questions that I think are more current, are more topical, are more exciting, so that one, as Professor Segui has indicated as well, so that we begin to get our work published throughout the world. If we're not going to then ride this wave, we'll have several challenges in making sure that our work is read throughout the world, and then our institutions in the country can also be, noted. That's what we need to do as institutions.
Well, my pulse has increased. My palms are sweaty. I'm tripping over my own tongue because I can't wait to hear who the winners are. But before that, let's go to that Colgate ad.
Good afternoon, ladies and gentlemen. On a cold and rainy day here in Johannesburg, it is my hope that you are all well and healthy at this time, and that it has been a good year for all of you. Firstly, just my sincere thanks to Professor Bayat and the Executive Committee of the IADR for this opportunity, just to say a few words and for Colgate to be able to sponsor toward this great event. I can honestly say that it is an honor and a privilege for Colgate to be involved with the IADR, and Colgate really recognizes the importance of the efforts of the IADR in improving the dental profession at large. So then also just a big congratulations to all the winners of the undergraduate, the postgraduate and the community competition categories. Just from our side, thank you for all your hard work and your dedication. I know everybody in the audience firsthand knows how challenging it is to do research. So we really hope that you are going to celebrate well and that you are going to enjoy the prizes that you are going to receive today. Ladies and gentlemen, if you permit me, I'd just like to just share a few initiatives that we, Colgate as a company, are busy with in community settings in terms of improving oral health. I'd just like to touch on our involvement in prevention, and they're specifically looking at the reach and education that we're doing. We're involved with the teledentistry project. We are also busy just revamping our BSBF program in exciting ways to make it more effective. And then we are also involved in funding the treatment of oral disease in South Africa. So firstly, I think all of you know that our community-based oral healthcare promotion program is called Bright Smiles, Bright Futures, and it targets school-going children in grades 1 to 3. And really the core of the program involves the giving of oral health education to children as well as to their teachers. Now at the moment we're active in about 16 countries, starting from South Africa all the way in the south up to Ivory Coast and Senegal on the West Africa, and then to Tanzania and Kenya on the east side. Now in 2020 we plan to reach 9 million children with oral health education as well as with educational material, toothbrushes, and then obviously toothpaste. But as you know, due to COVID, all of us experienced school closures in the various countries, which lasted a lot longer than expected. But in 2021, we're hopeful that we would be able to reach those 9 million children, and hopefully the second wave of the COVID pandemic will not hamper our efforts. Now, An addition that we're busy making to our BSBF program is to start to include brushing programs, so that we obviously not only give oral health education, but that we can make that next step and actually help children in schools to start brushing. And in South Africa, we have partnered with the National Department of Health, and this year we are supporting the National Department of Health's brushing program involving about 60,000 children. And then in association with the Dental Wellness Trust, we also sponsor a brushing program for 15,000 kids in the Western Cape, there on the Cape Flats. And it's really our hope that going forward we can really increase this initiative as well. And then we're also excited to bring back hand washing into our BSBF program in South Africa. From next year onwards, the 2 million kids that we plan to reach in South Africa will not only receive oral health education, but as well as hand washing education. And we also are implementing that in 4 other countries in East West Africa. And hopefully that will really become, again, a permanent fixture of our program. Then we have started, obviously, I think as a lot of you have also had to do this year, due to COVID, I think we all had to start thinking out of the box. And it was quite challenging in terms of providing oral health care. So what we did was 3 things that we added to our program or changed. And the first is that we started using animated oral health education videos, and we airing them on national TV stations in some of our countries. So hopefully next year we can continue with that. And we're also busy at the moment with some research in the form of household surveys to see what was the actual effect of that education on our target audience. And hopefully we can share that with you in the near future. Secondly, we also, because we do not have direct contact with teachers, we started developing an online training platform with which to reach and educate our teachers in oral health. And we did that in Kenya and Mozambique. We got some very good results and good feedback from both the teachers as well as the Ministries of Education. And we will definitely next year use that, but more in our urban settings, because as you might know, in rural settings, one often struggles with electricity as well as internet connectivity. And then thirdly, we started to develop a WhatsApp platform with which we will send digitized educational messages to both teachers and to parents. And hopefully they will then obviously use that to educate their kids at home. Another project that we are very excited about is the one of teledentistry that we started in South Africa this year. And the reason behind it is that Colgate as a company are always looking for innovative ways how they could support the profession. And what we did here in South Africa is to partner with the various dental universities, specifically the departments of community dentistry, as well as the Pelapepa trains. And the idea is really just to see if teledentistry as a tool could possibly help us to increase the access of oral health care to people in our rural, especially in our rural communities. So hopefully in the next few years, we would be able to see if this tool could help us in South Africa. And then, as I mentioned, I think all of you are aware of the Pelapepa train. I know most of us have already done service on that train. It was an amazing learning experience, and for me personally, it was some of the best food I've ever had. So that's maybe the first reason why I miss it. But I think we all know, the amazing work that the Pelapepa trains are doing in the various communities of our country. And this is really, I think, a great way in which Colgate are making a contribution to the treatment of oral disease in South Africa. And the company will definitely, going forward, still be supporting that initiative. And then, ladies and gentlemen, lastly, just a little commercial inset. I want to really just remind you, for those of you who don't know about our new product, Meridol. I think most of us know that in our country, more than 90% of people are affected by gum problems. And as such, Colgate has launched this product at the beginning of the year. And Meridol has got a unique formulation of amine and stannous fluoride, which really have got great benefits to counter gum problems. So I would really, if you haven't tried it yet, really encourage you to try it and to please be on the lookout for that. It is sold by dentists as well as pharmacies in South Africa. So ladies and gentlemen, with that, I'd just like to thank you for your time and for this opportunity. And our congratulations again to all the winners, and we wish you well for the future. Thank you very much.
Well, thank you very much to Colgate for keeping our smiles shiny. Since I was born, I've always used that product. So, and thank you for being a big sponsor, because right now the competition that we had for the posters is about to be announced, and it is the Colgate competition. Let me hand over to Professor Bayat and Professor Madiba, who are going to take us through the winners. Is there a drum roll? No. I need a drum roll, because these are big winners, aren't they, Dr. Bayat?
Yes, the stakes are high. The winner for the undergraduate competition will get about 12,500 rands. The winner for the postgraduate competition gets about 20,000 rands. And they will represent South Africa next year at the American IADR Congress, which is going to be held in Boston. So yes, the stakes are high.
Okay, so you can hear there's a handful of people in this room who are sitting 1.5 meters away from each other, and they're clapping hands. That's going to be our drum roll, okay? So when I cue you, please do clap your hands again, because the stakes are really high, and whoever the winner is, remember I was saying that I need this winner to be someone that I align with? Those winners who are going to Boston, I am going with them, I represent them, I translate English from English. We agree, Professor Madiba?
We agree.
They need translate. You know, American English is Boston English, and South Africa is different. So they need me. So the stakes are really high. So you get Patricia, you get your 20 grand or 12 grand, and you go to Boston. My goodness, you get me as well. Okay, part of the package.
That's a package for sure. Yeah.
All right, let's take over to you. Do you need the drum roll now, Professor Bayat?
Let me first do a short intro, and then we could ask for the drum roll.
Excellent.
Okay. So fortunately or unfortunately, we only had one undergraduate entry. And like I alluded to in the morning, we need to stimulate more research amongst our undergraduate students. However, having said that, we also need to acknowledge students who have sacrificed their time and given up a lot of their curriculum time to actually complete the research project. So after much discussions and deliberations, the judges have all agreed that we will award the prize to, the drum roll comes now.
Drum roll.
To the undergrad students from University of the Western Cape, Ms. Talib and Valley. So, congratulations. There is some work still to be done, and the judges have given us quite a bit of information into where we can improve that. So I will forward all of that to your supervisor. You can then work on that and hopefully get it published. And if allowed, we could even maybe present us at Boston next year with our beautiful hostess as well.
It's a package deal. All right, I think it's time for us to then hear, this particular category with the postgrads, Professor Madiba, had quite a couple of participants, didn't it?
Indeed, 4 of them in total.
And all of them were brilliant.
All of them were good, high quality stuff, relevant, topical.
And for those the 3 who might not take home the prize, can they still publish their work?
Indeed,
can they still
can.
get to a point where next year, this time, we have them give us a couple of words around their projects?
Indeed, they can. They are going to go ahead and publish their studies and educate us and go on and inform us.
Might I just add something as well? The feedback that we've got from the judges will all be passed on to those students as well. So they will also improve their research protocol. So when they do submit, they will get a much bigger audience view, because they will get feedback from not only the supervisor, but from all the judges as well. So it's only going to improve their end product.
Excellent.
Ladies and gentlemen, I am going to introduce the winner. But before I do that, I must say I have been in between professors the whole day. And by association, you have heard I am now a professor. I must just confess that I'm a doctor, and still is. Thank you. We have had...
Doctor, I think it's your twin that I mistaken you for.
Yes.
Please forgive me.
I do think so. Thank you. Ladies and gentlemen, we had 4 postgraduate competitors. The first one was Dr. Mufulo, and the topic was pregnant women's knowledge and attitude about ECC, and these are an important cohort. We are all here because of this important cohort, and this study was challenging and informative and, high quality. The second presenter, not in the order that they presented, was Dr. Vishal Bika, and he talked about the relationship between pericoronitis and the positioning of impacted mandibular third molars, a very important study, and we have now understood that more of the women tend to have these third molar impactions from this study. And then we had Dr. Mulik, who talked about karyogenic potential of natural sugar substitute, and she talked about xylitol, erythritol, and stevia, and this was an important topic because all of us are now going to the sugar substitute. And the fourth presenter was Dr. Nuren, and the topic was the effect of combination therapy of fluconazole and amphotericin B on Candida glabrata, a topical topic and very informative. And I must say, just before the drum rolls come, all of these competitors, presented high quality research and very informative, and we have taken and are taking lessons home from this. And unfortunately, the world works in a certain way. You only have one winner, and that is our situation today. But I must encourage you guys, you did well, and I know you're going to go ahead and publish this research and inform the greater population out there. Can we have the drum roll, please? And the winner of this postgraduate Colgate competition is Dr. Nuren with the title, The Effect of Combination Therapy of Fluconazole and Amphotericin B on Candida glabrata. Congratulations, Dr. Nuren. Well done. Thank you.
Congratulations to everyone who participated in the Colgate competition. Well done to all of you. Your efforts have been highly noted, and I am glad that the judges and adjudicators are going to submit to your supervisors all their feedback so that you can further your research and make sure that you hit us running with those publications. I can't wait to see them and read them and obviously see the impact that they're going to have in the dentistry field. Thank you very much.
Thank you.
With that, it is time for us to say well done to everyone who has participated in the first day of the 50th IADR virtual conference that has been sponsored by SMU and Colgate and other sponsors. We are very pleased that the first day has been such a great success. Make sure that you are tuning in again tomorrow. We need you here because you are critical to the work that is being done, and IADR and the SMU University would love to make sure that you interact constantly. For those who did not join us, please tell them that they missed out on a great day today, but tomorrow is another opportunity for them to join us, and they can do so by going onto the website www.smu.ac.za/IADR/2020. So make sure that no one misses out on tomorrow because we've got great speakers, great guests, and it's going to be very informative. Also, make sure that you are commenting on the Facebook page and you're commenting on YouTube and Twitter so that we all see and hear what your views have been. From myself, Patricia Ntuli, until tomorrow, have a blessed evening.